We're live now, Chairman.
Thank you, Jonathan. So good morning and welcome everybody to this, the last scheduled meeting of the Healthy Staffordshire Select Committee for this County Council session. As ever with these changing times, so much has happened in the last 6 weeks since we last met. We've seen the death toll from those with a positive test within 28 days of COVID rise from 100,000 last time we met to 125,000 across the UK. However, on a positive note, the level of vaccination locally has gone from a standing start in December to over 460,000 people in Staffordshire and Stoke-on-Trent as of last week, against a population requirement of 930,000 people. And in the middle of all that, we're dealing with a mutating virus, and we may talk about that at some stage, and this will clearly change the way we live all of our lives. And every death is a tragedy and puts into sharp focus, if we ever needed that, the importance of the health service locally and the role that we play here today. So welcome. This morning is Tuesday, the 16th of March, 2021. I am your chair, County Councillor Jeremy Pert, and this is the Healthy Staffordshire Select Committee. Can I welcome you all? Can I extend a welcome to all our guests from the Staffordshire CCGs, STP, and from the County Council, and in particular, welcome to Dr. Richard Harling, and congratulations on being awarded an MBE in the last Queen's New Year's Honours List. I think it's the first time you've been before us subsequent to that, but don't expect an easier time just because of it. This meeting is being held by the magical properties of Teams, and I know members will be very much familiar with how that works. Please can I ask that we keep microphones off when not speaking to make the discussion easier for people to follow through not having background noise. Can we keep cameras off when not speaking to protect bandwidth for the rest of us being able to follow proceedings? Can we use the raise hands button if we'd like to ask a question? I will try and pick those up. And finally, if you need to leave the meeting early, please can you let me know through the chat function. I'm aware many of our guests need to leave at various times, so we'll stick to the original agenda, but can I just encourage people, members, to be as alacrious as possible and not to give lots of background detail, regardless of my long starts to this meeting. Let's move on to this morning's agenda. First of all, apologies.
No apologies received, Chairman.
That's a good way to start. Thank you, Jonathan. Can I just confirm that we're quorate? If there are no apologies, we must be. So let's move on. Number 2, declarations of interest.
Yes, Chair.
Councillor Edgeler.
Thank you, Chairman, and good morning, everyone. I'd like to declare that I'm a partner governor on the MPFT.
You very much are, and thank you. Anyone else? Thank you. I will move on to item 3 then, minutes of the last meeting. Can I ask if the minutes are a true record of the meeting on Monday, the 1st of February 2021? For those who are there, were they a true and accurate record? Can I have a proposer and a seconder?
Happy to propose, Jeremy.
I'll second that.
All. Thank you.
I'll second that.
Anne, appreciate that. That's fine. Sorry, I should have mentioned. I'll have to wake up. I should have mentioned that under item 48, integrated care systems, we've not deliberately left Marcus Warden's attendance at that meeting off, but I would like just to add that to the minutes. And can we correct the spelling of Lynn Miller, because I think she is L-Y-N-N rather than an L-Y-N-N-E. But apart from that, sorry, can I just take that vote again that we're all in agreement? Paul, are you happy to propose? Anne, are you happy to second?
Yes, correct.
Yes, Chair.
Thank you. Are we in all agreement? I'll take that as yes. So let's talk about matters arising. We had a few matters arising from the previous sets of minutes. Jonathan, WIMAS, West Midlands Ambulance Service and the first responders. We were waiting for some details from them. Can you just give us a quick summary in terms of where we're up to with that action specifically?
Yes, we had a reply from the Trust yesterday with some additional information, setting out basically their latest response times for the county compared to other counties. There's various other information, but I can circulate the email, Chairman, if that would help.
I think that's would exactly help members. There's lots of data in the email, and as Jonathan's indicated, I don't think either of us have yet got to the bottom of all of the data that's there. So, Jonathan, if you're happy to circulate that, and if members have any further follow-up, either questions or comments, let's circulate those to committee through email, please. Is there anything else in terms of matters arising, Jonathan?
We met with Mr. Latham, didn't we, Chairman, about various issues which we have taken forward, and we've had replies from Marcus about the performance of the South East Staffordshire and Eastern Peninsula CCG. We've also had email replies from Neil Carr about the George Bryan Centre, and Gavin Boyle about the future of the Samuel Johnson Hospital. And again, Chairman, we can circulate those to members, well, Mr. Latham and or the other members if required.
Can I suggest, as I guess we all get lots of email, that we circulate them to the relevant members rather than to all members, unless someone would like to see the responses which relate to those areas. Janet Eagland.
Thank you, Chairman. I was going to bring up item 50 on the any other businesses, but I'll bring it up now. Yes, I would appreciate Jonathan sending any information to me and to Councillor Latham, the representative from Lichfield District Council, because we had a meeting, if you recall, about these items that are concerning the committee. So yes, I would appreciate that information being forwarded.
Brilliant. Take that as read. Does any other member outside of the Lichfield members want to see those elements?
Yes, please, Chair.
Okay, let's circulate round all members, please, Jonathan.
Will do, Chairman.
Thank you. Good. Anything else arising from actions and from the minutes? I'll take that as a no. So let us, members, with your permission, move on to item 4 of the agenda, COVID-19 vaccination programme update. Paddy, I believe you're taking this.
Thank you. Run through some numbers first. The programme is going well. The Health Service Journal last week in the league table of CCGs and STPs, Staffordshire and Stoke-on-Trent was the highest CCG in the country for over 65 uptake levels, which was good to see. As of Monday morning, the figures are that we've done 468,000 first doses and about 30,000 second doses. Hope to breach the 500,000 barrier probably tomorrow. There's a little bit of lag in the figures. Last week we did 49,000 vaccines across Staffordshire and Stoke-on-Trent, and that rises this week to 79,000. There's a significant step up in tempo of the programme from this week onwards. We're now getting into a fairly significant degree of second dose vaccines, together with continued first doses. The national supply chain is increasing, and so, as I say, not quite a doubling, but virtually a doubling of volume this week and beyond. So we are going to see some acceleration. Program's probably best described at the moment as sort of two broad thrusts. One is volume, getting through the numbers, and then the second thrust is really trying to get high levels of uptake in the various cohorts. So to speak to the sort of first element, as I've said, the numbers so far are pleasing and the volumes are going up. In terms of the first 4 cohorts, we know that we're into the low and mid 90s in percentage uptake. In our cohort 5, which is 60 to 64, we're at 90%. Above 55, it's 79%, and in the 50 to 55, it's at 39%. So all of those cohorts are being invited in at the moment. We've got quite a lot of people now booked into the vaccination centres over the next couple of weeks, and we're starting to get a little bit of noise that we're sort of searching for patients in those cohorts. So we're getting through those fairly quickly. The largest cohort to date is cohort 6, which is everywhere between 16 and 65 with long-term conditions. It's 2 to 3 times the size of any of the other cohorts. We're currently at about 71% uptake in that cohort. It's quite a grind, but the GP sites, the local vaccination sites are working their way through that. So in terms of capacity, we're doing well in terms of the numbers. Moving to the sort of second area, which is the sort of harder to reach groups and trying to achieve high uptake. We've got a number of sort of sub-programs, so to run through them quickly. Care homes, we've now visited every care home in Staffordshire. The vaccination uptake rate in care home residents is about 94%. Regionally, I think we're second highest in the region for percentage uptake, and 94% is I think probably a fairly good uptake level. But again, still working on that, and certainly anybody who gets discharged or admitted to a care home, we will ensure that they get vaccinated if they haven't been vaccinated to date. Our programme for the homeless population started last week, and 65 people in Stoke-on-Trent were vaccinated. We have similar programmes that will cover Staff's County Council homeless populations. We think there's probably about 250 people that we need to cover off in this group, but we've started that and will continue. We've been working on learning disability, both in residential and community settings. We know that the uptake rate in the learning disability homes is around 80 or mid 80%. So I think it's about 87%. In the whole LD population, the uptake rate is around 77%. There were some figures quoted regionally last week, mid 60s, but we've stripped out the children from that because obviously we're not yet vaccinating children, and that has made about a 10% difference to the figures, so it's about 77%, but still working on that. Working on the BAME community, we had some pop-up clinics last week. We had one in Burton last week with good uptake rate. Difficult to get figures for this because the source of BAME ethnicity comes from the GP records, and the way it's coded within the records is not particularly robust. So we are struggling to get some decent numbers around the BAME. When I last saw comparative regional figures, this is probably our weakest area, and compared to our regional peers, we were lower than a lot of other areas. So it's probably the one where I would have most concern, and the absence of robust data around it makes it slightly more difficult. We do have quite an extensive programme of using community assets, local community leaders, particularly driven through the comms team around trying to improve uptake in this cohort. We're starting to do a little bit of work to see whether there's any issue around asylum seekers as well. So I think we've got a range of programs to try and improve uptake across each of those communities. Our health and social care staff, we've continued to both improve the quality of the data through the care home tracker and also uptake levels. There were a couple of webinars last week for staff. The overall figure for the county is 78% uptake in care home staff. I think that was 79% for Staff's County Council and 76% for Stoke. A number of sort of myths and issues around vaccine hesitancy, particularly in younger staff or younger BAME staff. And so we're just chipping away at that through a range of initiatives and seeing a slow but steady increase in uptake in these groups. So overall, I think both in terms of volume and penetration, we're doing reasonably well. My concern would be around BAME, is the area that we would want to perhaps keep our eye on. increase in tempo this week and increasing volumes and the sort of, but we're certainly keeping up with the sort of national acceleration of delivery of the programme. Thank you.
Thank you, Dr. Hannigan. That's very helpful. Before I just take questions, can I just ask one, I think, question that probably concerns us all? Do we have the sort of physical capacity to jab people based on the amount of vaccine available to us? I.e., if there is extra vaccine, will we use it within Staffordshire, and do we have the capacity within the system to be able to use it, please?
Yes, capacity isn't a problem. We've got our 4 pillars from our hospital hubs through our vaccination centres, which are increasing their capacity quite significantly and have actually really quite a large potential reserve capacity if we needed it through the GP sites and then our sort of roving teams, which are effectively largely our GPs, but also some MPFT teams. So I think capacity is not the issue. To date, it's been the vaccine supply chain that's been the rate limiting step. There's been, as you can tell, a national acceleration in the programme, and capacity won't limit us in our ability to do that, I don't think.
Thank you, that's very helpful. I'll take questions in order I saw them. Anne Edgeler, please.
Thank you very much, Chairman, and thank you, Dr. Hannigan, for all the good work you're doing. All the good feedback we get from people is fantastic. My question really is, knowing what's happening in other countries regarding the AstraZeneca vaccine, have we had any people in this country refusing to take it because of what's happening on the news media and everything? I just wondered if we're having a kickback from people here. Thank you, Dr. Hannigan.
Broadly speaking, no. It's very hard to find people who are refusing the vaccine. We can fill all our capacity. Our initial sort of refusal rate was we've been quoted back from the sites who were phoning patients at 1 or 2%. So I think absolute refusal is quite small. I think hesitancy is perhaps an issue. So there's a group of people who sit on the fence and are persuadable. You just have to identify what their individual issues and arguments are, and you do need to take it down to a very localized or almost a personal message to that patient. So be it concerns around the how the vaccine was approved, or is it concerns around what the vaccine contains? But it is down to almost an individual reason. But I think that to me is just a problem we need to work our way through. So our sub-program approach with attention to numbers and then quite a range of tools we're bringing to bear to improve it. But no, I don't think the AstraZeneca or any of the other sort of issues are I think they're anecdotal really in terms of its effect on our uptake levels at the moment. It remains to be seen whether we get into sort of younger age groups, whether views will change. It's quite different when you're speaking to somebody over 80 and you're basically talking about your individual personal benefit. When you start to talk to younger people, you're really talking about population benefit, and the argument shifts and the reasoning needs to shift with it.
Thank you very much. Thank you.
Want to come back, Anne? No,
thank you, Chair. Thank you.
Thank you. Dave Jones.
Thank you very much, Chair, and thank you for covering the content previously. I've just got a couple of questions to ask in terms of not uptake of vaccination, but rate of offering of vaccination. I've had a number of residents across the north of the county in Newcastle and in the Moorlands contact me or contact colleagues about some disparity in terms of what age range or what level of priority is being offered vaccines in the county compared to other family members in perhaps the metro areas. So where there are younger family members, less at risk family members, lower priority family members who live in the metro areas that have been vaccinated, whilst higher priority family members in Staffordshire haven't been offered the vaccination yet. And then secondly, there appears to be a bit of a disparity within Staffordshire. I know that certainly in my part of Staffordshire in Keele, there's through the GP, there's a lower rate of vaccination going on, or offering of vaccination going on, compared to other areas of the county. So I guess it's really just to get a little bit of take on the disparity in offering of vaccinations, but also a request: could we receive some more granular data, or certainly I'd be very happy to receive some more granular data on rates of offering of vaccination within our patches, because this is something that we can encourage and try and ensure that our residents are taking up the offers that they get for vaccination, because of the requirement to get as many vaccinated as possible, and the potential supply of those vaccinations.
Thank you. I mean, everybody's following the JCVI categorization and cohorts, and broadly speaking, the programme I think has been fairly true to that. So if you look at the sort of data that we're getting, you can see the cohorts filling both locally and at PCN level. We can sort of see the rate of fill of each of the cohorts, and we can see our comparison certainly at regional level. And actually, it's pretty comparable across the piece. I think everybody's probably going at reasonably similar speeds, and the variation is relatively small. There is a little bit of lag in the system, so it takes sometimes a couple of days for data to get into the system. So we're always looking at it, and the volumes obviously are very high. So there is a sort of distortion effect that you get, and it's quite difficult to sometimes to sort of get a complete feel for it. But I think broadly everybody's going at roughly the same speed, and this has been the national policy, and did cause a bit of controversy right at the beginning, when people were really saying your rate is going to be slowed down, and the vaccine coming to a particular area was going to be reduced, and it was going to be shifted elsewhere to keep everybody effectively in line abreast. And certainly the national noise, and we had a webinar with Simon Stevens and the main team last week, and this sort of idea of everybody sort of going in unison is really the sort of national steer, and I think is working both at regional and in this sort of Staffordshire level. The trouble is there's a huge amount of sort of anecdote, and everybody's very keen to get this vaccine. So when you hear that somebody who appears to be in a different cohort is being vaccinated elsewhere, that news travels on social media fairly quickly. And a lot of it is anecdote, and we spend an awful lot of time firefighting stories that are coming in from all of our sites about, the GPs say the pharmacies did that, and the pharmacies say the GPs did this, and everybody's sort of accusing each other of going too fast and not staying in the cohorts. But the actual numbers that we're seeing suggest that they are. So I think we need to be careful of the anecdote. It also, things like long-term health conditions, cohort 6 between 60 and 65, it's not always very obvious to people what health conditions friends or neighbours may have and their eligibility, and it's quite difficult sometimes to explain that. So I'm reasonably confident that Staffordshire is following at the cohorts according to JCVI, and we're all going roughly in unison. The disparity across the different PCN sites, we see that across the 23 sites we're running, and we can see the variability. And again, the rate of fill across each of the cohorts does sometimes look different, but often that can be as simple as, if you get 1,200 Pfizer vaccines on a Monday and give them on a Tuesday, on a Wednesday your figures look 1,200 better, and the practice down the road maybe getting their 1,200 on a Friday. So again, it can look a little bit at a sequence, but in reality, I think we are moving in unison. Granular data is difficult. We did get some early data last week on by ward, but it was just pure numbers, and the pure numbers aren't helpful. I mean, to know that 300 and something people in your ward have had a vaccine doesn't really tell you anything without the denominator population. So it's not very helpful. We have struggled at the beginning of the programme to get decent quality data, but we're now getting data certainly at site level. We're now updating sort of 3 times a week, and it is robust despite the fact we're getting the lag. We have sort of tried to look at getting out some more useful figure to partners such as yourselves, but as I say, it's quite difficult to get it at sort of at ward level in percentage terms, and again, because it's moving so quickly, unless it's timely, it just again just gives you a distortion. And by way of reassurance, I would just say that I think we are, we are holding our own, and certainly our figures, going back to the HSJ article, we're doing well compared to our peers.
Thank you. Dave, do you want to come back on any of those points?
Yes, just very quickly, because I respect time on the meeting. Just to thank you that I do agree with the anecdotal evidence. It's very difficult to sometimes deal with that. I think in these cases, it's residents who are talking about family members that they know exceptionally well. So it's slightly less anecdotal, but still potentially anecdotal. And really, when residents are calling me, it's being able to reassure residents by having seen the values for myself. I don't like to reassure residents if I haven't seen those numbers myself. And it's really, if you would just be, it's not something we need on a regular basis, but if you would be happy just to send something through that says that the rates, the offering of vaccination is to the same priority groups across all PCNs and is in line with other vaccination areas within the country, that would certainly be something that I could hang my hat on when going back to residents and say, actually, we are on target with the rest of the country. It's not something that's specific to where you live, which GP practice you're registered with, or essentially that. So that would be appreciated. Thank you.
Happy to take that away and see if we can produce a report.
Thank you. I would just also comment that when certainly I've seen any exceptions and cases that when we've presented them through to your team, the responses have been very quick and effective. So thank you for that. So I would encourage other members, if they are aware of exceptions, just to put them into the team, because, first of all, there will be some people who are missed, not deliberately, and I'm sure that the mantra of the Paddy, just remind me of the mantra of the vaccination program.
No one will be left behind.
Thank you. Let me take Bernard Peters.
Thank you, Chair. Thank you, Dr. Hannigan, for your report. I'd like to frame my report in a certain way here, because one of my divisions in East Staffordshire is Horninglow, which of course is a hotspot. And I'm hearing a lot of messages from a very, very diverse community in that area. And for the last 3 or 4 sessions I've been to, and Dr. Hannigan, you've been at most of them really, and I have to say to you, I do recognise the good work that's going on, but it's a repeat message. In as much as we're working through this and we're chipping away. Now, what I'm trying to get from you is, and I've heard what you said today quite clearly, but I want to get assured that there really is a sense of pace around this, because there are people who are anxious, have some anxiety, and I frame myself in that group, although I don't live near Horninglow. I'm a type 1 diabetic, so I am close to what's going on because of my own welfare. And I just wondered whether, I'm almost certain that you will assure me you are moving at pace, but could you be moving any quicker in terms of saturating particular hotspots in East Staffordshire? Thank you.
The pace is determined by the rate of vaccine coming into the system, and we never refuse vaccine, and we get short calls for additional vaccine occasionally, and we always say yes. So we move as fast as the vaccine flow allows us, and I say that's a national, in fact international supply chain issue, and we've always sort of taken the view that we will accept anything that comes in. So that's our main rate and pace determining step. The sort of second principle is that, as we described in the previous answer, is that we're trying to keep to the JCVI cohorts, and we're trying to do that equally across all our geographies. So we do try and keep in line abreast, and the vaccine distribution from region down to our sites is based on their level of uptake against each particular cohort. So we have a very short lead-in time of sort of 1 to 2 weeks with the vaccine delivery, and they are looking at our uptake rates in each area. I don't think they specifically look and factor in outbreaks. I think one of the sort of principles behind the whole national program is to try and keep it as simple as it is. It is quite complex, but they have, and I guess it's one of the principles you've probably seen through this JCVI, is that they've resisted the temptation to try and make this more and more complicated in the way that vaccine is distributed. The latest one was that we would base all of the vaccination going forward on age, and we would not go down the route of looking at people's professions and the key worker groups. And that was just basically on a broad principle that we want to go as fast as possible, and the more complexity you layer into it, probably you slow yourself down. So I don't think outbreaks drive distribution. I think the pace is as fast as we can, and we pay a lot of attention to where each area is in its uptake rates, and that's our focus really, so that, as I said, nobody is left behind, and we're not seeing sort of variability across the whole county in uptake rates, or at least undue variability, and certainly when there is variability, we then try and work out why and fix that.
Thank you. Marcus, did you want to come in on this?
Yeah, please, Chair. I think Paddy's sort of is very modest, and I think was being perhaps very modest at the beginning in terms of sort of how we're doing on this. We are one of the best performing systems in the country. The HSJ put us at the top of 42 STPs and ICSs nationally. So in terms of the comments around sort of how quickly we're rolling it out, issues, Councillor Peters, around pace. Yeah, we are actually doing incredibly well in terms of rolling the vaccine. We've got the lowest stock levels as well of pretty much any system in the country. When we get it, we jab people with it. I had my vaccine on Friday at the county showground, incredibly slick. Yeah, I got my letter, I had my jab literally sort of the next day. So I would want committee members to be assured that we have more than enough capacity. As Paddy said, I think we're probably expecting around about 80,000 doses of the vaccine this week. The highest week to date is 53. We've got capacity to do over 150,000 jabs a week. So in terms of keeping up the pace around the first jabs and giving the second jabs when people get to the 12 weeks, we have more than enough capacity. At the moment, 77% of all of jabs have been delivered by our GPs working through our primary care networks in the local vaccination centres, 11% by the hospital hubs, which are largely health and care staff, 8% through pharmacies and 4% through the vaccination centres. So those 3 vaccination centres at the moment are only doing around about 4% of the total. They will come into their own as we get down the lower age groups and as we start really ramping up the second doses. And let's not forget, this is going to be an annual programme as well. So it's something we are going to have to do every year. So I would say to members, we are blazing the trail on this. We are amongst the most efficient deliverers of the vaccine in the country. We are going at pace. We're jabbing people as quickly as we get the vaccines through. We've got low stock numbers. Paddy's been the clinical lead for this, and general practice has played an absolute blinder on this. They vaccinate every year, and what we've done literally is set up a medium-sized supermarket chain literally within a matter of 4 or 5 weeks to jab people. So, I think where we are at the moment, I think as of Monday we were, I think 49% of our eligible population have already had at least 1 jab. It's 39% of our total population, given that we're only jabbing people over 18. So, I would want members to be assured that we are doing this as quickly as we can. And whilst we do have some issues around some of our BAME communities and some of our harder to reach, more disadvantaged communities, I think this is a real success. And I am absolutely confident that we will deliver the April the 15th deadline to do priority groups 1 to 9. Lynn tells me we'll probably do that by the end of March. And in terms of the national ambition around everyone being offered a first jab, all of our adults by the end of July, we're potentially looking at based on the capacity we have, and as long as the vaccine supply holds up, which we're confident it will, we're probably looking at potentially 4 to 6 weeks earlier, delivering against that target. So please be assured this is a real success story, and we're doing everything we can to ensure that no one is left behind and people get the jabs, are offered the jab as soon as we get to their cohort in line with the JCVI guidance. Thank you.
Thank you, Marcus. Do you want to come back, Bernard?
No, just a brief comment, if I may, Chair. Dr. Hannigan and Marcus, thank you so much for that. I do feel assured by those words. And I'd just like to pay tribute before I go off to the imams at the mosques in Burton who have gone that extra mile, supported by Dr. McMahon as well. So in terms of joining the dots and working together, I really get a sense here of a team approach to it, and I'm just privileged to be on the edge of it. Thank you, gentlemen.
Can I just ask a follow-up, which I think is really relevant to all of the points being made, particularly about the BAME community, which is, what is your ask of members of this committee and other community-based leaders to make sure that those harder to reach groups that we talked about earlier can be effectively picked up? Who wants to pick up that? Paddy?
I'd just say that leadership, that constant sort of message that we all need to have our vaccine, and that we will work with any individual community or group or individual about trying to understand their reason for vaccine hesitancy, if that's the issue, and answer their questions. So we, through our sites and down to individual GPs, we've got a commitment right through the system that we will offer the vaccine to every single resident. And, if that means an individual conversation, then that's what we'll do. And so we've got, as I say, a range of programs trying to do that. And so the message I think we would want is to engage with us, let us know what the concerns are, and we will answer the questions.
Thank you, and welcome members taking up that offer. So, Paul Northcote.
Thank you, Mr. Chair, and thank you, Paddy, for your illustrative directive this morning. What I want to pick up on, and it's something that Councillor Jones mentioned briefly, was the disparity in the north of the county. Now, my mailbox is absolutely full of people asking me. They say they see the success of Staffordshire, and I've got no problems with that, with the Staffordshire rollout. They're seeing the amounts of figures that have been quoted in terms of vaccination delivery. But may I just illustrate an example of cross-border arrangements? Now, I've raised this via the Outbreak Board, my concerns over the last few months. But I feel this needs to be escalated now in terms of, for example, there's a 10 GP practice in Market Drayton that services people in Staffordshire, quite significant amounts of over the border in Loggerheads, Ashley, Baldwinsgate, etc., that aren't giving vaccinations. They're claiming that they're not being approved as a vaccination centre. And this is having a massive impact in terms of the north of the county, with residents contacting me to say they're not even being offered vaccinations. I have a lady who has had 20 years being diagnosed with MS. She has yet to be called. They're not even identifying her. Significant failings here. Now, this has been highlighted by the MP and the Owen Patterson for Shropshire and in the media recently, but the practice are actually refusing to, I'm informed they're refusing to act as a vaccination centre, and patients having to travel huge distances to Telford, to Priest, to Oswestry to accept the vaccinations, even though they live in Staffordshire. That they're not getting that sort of access that's been afforded to elsewhere in Staffordshire and the metropolitan areas, which everybody seems to be enjoying. So they're seeing this on the ground, and they're wondering why on earth this hasn't been rolled out equitably. So my question is to make sure that we're having those conversations with cross-border partners to make sure that this isn't happening. And we're not talking about a handful of residents here. We're talking about significant numbers in terms of hundreds, if not thousands. Thank you.
One of the strong points of our county response to this has been that we have 149 GP practices, and every one of them is engaged with the delivery of the programme. That's not the case in other parts of the country, where whether practices engage with the programme is a matter of choice, and in some areas GP practices have declined to take up the what's called a direct enhanced service to deliver the vaccine. But certainly in Staffordshire and Stoke-on-Trent, all of our practices are involved. They work at scale through their primary care networks, and that's why we have the 23 sites, the 23 PCNs that are engaged with this. So if you're registered with a practice in county, this should not be an issue. The point you make obviously is our cross-border patients where you may be registered with a practice outside the county, and that will have been a problem, because 77% of our vaccination in the first four cohorts was delivered by GPs, and therefore access to particularly the vaccination centres and the community pharmacy in the initial phase of this would have been restricted. I hope that problem will now have disappeared, or will imminently disappear, because as Marcus said a moment ago, our vaccination centres, which only did a small proportion of our vaccination in the first phase, they're now ramping up, and the volumes going through that. So there's effectively been a bit of rebalancing happening over the last few weeks, where the vaccine flow, and as we increase the tempo this week, the vaccine going to general practice proportionately will be less, and will increase in both the community pharmacies and the vaccination centres. Also, the national booking system is now it's improved and changed, and they're now using text messaging and sending letters. So the patients that you describe should be getting the offer to go to vaccination centres, should find it easier to book through the 119 number, and will be able to come in county and not have to go to Birmingham or further away. So I think that problem should, if it hasn't already disappeared, should imminently disappear. But I will take away the issue around that Market Drayton, so that geographical issue. I will talk to the primary care team around that specifically, because if there are large numbers registered in Market Drayton and they have no access, then it may be a local problem. And I need to go and have a look at the local PCN figures as well, and just see what that looks like. But we can take that away in the primary care team and look at that.
Thank you, Paddy. Once you've looked at that, could you just drop a note back into this committee, and then we'll circulate that to Paul, so he has that view as well, please. Marcus, do you want to come in on this?
Yeah, I think it was just to, I guess, reiterate what Paddy said. The vast majority of vaccines so far have been offered by practices and delivered through the local vaccination services. The central booking system, which is for the vaccination centres, and we have the one in Tunstall, the one in Stafford, and the one in Balderwas, as well as pharmacies, are done through a central booking system. That's really ramped up significantly. And as Paddy said, I think huge numbers of texts are now going out as well, which will improve uptake. So I was just looking at our data on Foundry, which is the all the nationally available information around sort of how many vaccines have been offered and delivered. So Council Northcote, if there's a particular practice or PCN you're concerned about, we can drill down into the data, have a look at what the issue is, and pick it up with the practice. The majority of my correspondence from MPs over the last couple of months has been around vaccines, people concerned around I've not had an offer yet, people in Codsall saying, why am I having to travel to Telford? Part of that is because of where we are with the national booking system, which we have no control over. I think that's got better over the last few weeks and months. But as I said, this is, we only started vaccinating beginning of December. This is going to be an annual event. Some of those teething problems have been worked through. And I think the coordination between local booking through our local vaccination services and the national booking system, I think that will get a lot easier. So I think what you've just described around certain pockets of the population maybe struggling to access a local centre or not wanting to have to travel, I think we've addressed most of those issues. But if there's still a problem in Market Drayton and Council Northcote, we will pick that up.
Paul, do you want to come back?
Thank you for that, and I feel a little bit more reassured now with what you both have said. I'm very conscious that if this is going to be a yearly annual thing, I want to make sure that the problems are ironed out and this doesn't happen again, really, when we're in the same sort of conversation similar times next year. So thank you very much for that. Appreciate that.
Can I just follow up that set of questioning, because if this is going to be an annual programme, clearly the GPs and recruitment of GPs has been an issue for a long while, I believe. But if this is going to go on top of the day job, effectively, how do you envisage delivering that booster campaign? Given that there's a backlog potentially in unreferred cases, and this is clearly additional work to what they would have naturally been expecting to do.
I think that's going to require a little bit of reflection on the programme to date and the future anticipation around the programme. We think there's going to be boosters. We don't know the frequency of that, and we don't know the scale of it, and we don't know how it will be delivered. One of the successes of UK vaccination is it's based in general practice. I mean, that's how we get high uptake levels. We have the second most effective flu vaccination programme internationally, and the countries who have high uptake levels for vaccination tend to have well developed primary care systems. So disconnecting vaccination from primary care will probably result in a less successful programme. So the key is going to be how, if we have to do something at scale going forward, is how we combine the benefits of that registration with a GP and that relationship in terms of high uptake levels with what you're describing in terms of the capacity. I mean, a lot of our GP sites, they're described as GP sites, but they're using 70% of their workforce is additional workforce volunteers. That's been really effective. We've got a large volunteer and additional workforce programme run through MPFT that have supported the programme. Some of our sites are heavier on GP staff, and we've done a stock taking programme with the practices, and we are having conversations about resilience and the ability to double run, and we have sought reassurance that they will be able to do both things. But quite what it looks like going forward, I think there'll need to be a sort of national conversation about that. But certainly in terms of assurance at the moment is we think our practices are resilient. We think they will stay in the programme, and we are tapping into that wider workforce very, very effectively.
Thank you. Appreciate that insight, and maybe that's something that we as a committee need to come back to later in the year, just to take a view as to what that looks like from a Staffordshire point of view, and maybe we'll put that on the work programme, Jonathan, for the next committee to look at. I've got no other indications of questions. I'll give members countdown from 3, 3, 2, 1. Okay, so before I move on to the next item, I think Marcus gave a really good account of the success of the programme to date, and thank you for coming, Marcus and Paddy, to share that with us today. I wonder, given this is the last meeting of this committee in this council cycle, whether the committee might be minded to write to the leaders of the vaccination programme in Staffordshire and thank them for the work that they and their teams are doing in such a caring and slick fashion, particularly as I think Marcus indicated that Staffordshire's CCGs are one of the top performing, if not the top performing CCG in the country. Are members minded that we should write and express our thanks on behalf of our residents to the leaders of the vaccination programme?
Agreed.
Most definitely, Chair. Agreed.
Yes, most definitely.
Yes.
Agreed.
Agreed.
Yeah.
Thank you for that resounding agreement. I will send you a copy of that, and obviously ask Marcus and Paddy to express our thanks as a committee to all of those people involved. And frankly, I think you make a really good point that actually, if you're in your 80s, it's been a lifesaver for many people. So thank you. Let's move on to item number 5, which is the journey towards an integrated care system, stakeholder engagement. I'm assuming that will be Simon and Marcus. So who wants to lead off, gentlemen?
I'll start, Chair, if that's okay.
Thank
and then
you.
I'll hand over to Marcus. And aware of your comment at the start, so recognise that we've been to this committee a number of times to talk about the progress being made and the work that continues to happen, but really important that we carry on that dialogue. And indeed, one of the requests from the committee was that we carry on coming back and talking through the different strands and the different areas. And so today we're going to focus on the strategic commissioning aspects of that, and Marcus will pick up on the detail of the progress that's been made there. And hopefully colleagues should have slides up on the screen that they can see in front of them. Next slide, Anna, please. Okay, so just to set the context before then Marcus gets into the detail around the strategic commissioning element. When we came to the committee previously, we talked about the integrated care system development plan and the work that had happened around that. That's been to scrutiny, it's been to the Health and Wellbeing Board to be talked about, and as well as continues to be developed and delivered around how system partners are working together. I think a really important element, whether that be the COVID response, the vaccination response, has been how partners have found ways of reducing and cutting through bureaucracy and finding ways to empower clinical and professional staff to really drive change on the ground. And the whole modus operandi for the integrated care system has to be around how do we empower those local clinicians and local professionals to really drive service change forwards. Since we last met, that ICS plan has been approved, and indeed in February, Secretary of State for Health and Social Care published his white paper, Integration Innovation, working together to improve health and social care for all. The expectation is that that will go through the House for its first and second reading in May and June, and then will become legislation for April next year. It proposes a number of changes, not intending to go through that in detail today. A key part of becoming an integrated care system is the role and the transition of the CCGs initially to a single clinical commissioning group, and then the role of the strategic commissioner. But really important that we see the context and committee members understand the context of an ICS is much more than a commissioning reorganisation. It's absolutely about how do we work differently, both within the NHS, but also across health and local government, and with other partners, voluntary, third sector, and with local communities and the local population. So it's absolutely about how do we change the way that we work, how does the partnership work, but also how do we devolve as much as possible to our integrated care partnerships for local community-based working, which is where patients, residents recognise where they get services from, and that's built around our primary care networks and our GP practices working with community providers. Next slide, please. And I touched on this briefly already anyway. So the importance and central to the development of the integrated care system is our clinical and professional leadership. You just heard from Dr. Hannigan the importance of that clinical leadership in terms of the vaccination programme. You've heard previously in terms of the clinical and professional leadership in terms of the response to COVID and how services have evolved and changed to meet the needs of the population and to meet the needs of the challenge. So there's an absolute central tenet and central core strand of work around how do we empower our clinical and professional community to lead that pathway in system transformation redesign, but do that in a way of making sure it makes sense to local residents and makes sense to local communities. Marcus.
Thank you, Simon. Next slide, please, Anna. So, as Simon said, this is not about reorganising the commissioning side of the NHS. This is about a very, very significant reorganisation of the NHS in terms of how it does business and moving towards a much more integrated model of care, which is about integration from an NHS side, but also crucially with local authorities. So we join up the commissioning and provisioning of services to have a proper health and care system rather than both sides of the health and care divide doing their own thing. And I use the word divide advisedly because in previous years it has felt a little bit like that. So the creation of a single strategic commissioner is a means to an end. It's not an end in itself. And as Simon said, it is a step on a journey to become an integrated care system. What we did back end of last year, we had to bring this process forward to meet the national timelines. So we were actually looking to discuss merger again with our 6 CCG memberships in the summer. We've brought that forward. As Simon said, there's a legislative timetable to meet, and it is absolutely key that we get the vote to merge through in advance of that process starting. So back end of last year and beginning of this calendar year, we worked with our GP membership to understand what their issues and concerns were, because committee members will know that we had a no vote at the back end of 2019. So we worked very closely with our practices, with our local medical committees to understand what those issues were. Very helpfully, they set those 6 things that you need to assure us about for us to vote differently this time. We worked very hard with them on that and went back to them in February, and 135 of the 147 faxes voted yes, 92% turnout, and 84% of those were in favour. So when we did this in 2019, 80% voted against. This time, 84% voted in favour. So all 6 CCGs supported the vote. The only way the CCGs can come together to merge to create a single strategic commissioner is if the GP members vote for it, and they have done in overwhelming numbers. Next slide, please. And I think the work that we did with them, and Alison is on the call with me, who has led the merger campaign process, Alison Bradley, the clinical chair of North Staffordshire CCG, and Paddy's still on the call. We did an awful lot of working with our practices to understand their concerns, and I think the comments we received on the back of that, because we did ask our members to sort of tell us why they voted yes or voted no or chose to abstain in a very small number of cases. So I won't go through those comments there. You can see, generally speaking, there was a high level of support. The view was it's the right thing to do for our patients and citizens across Staffordshire and Stoke-on-Trent. And actually the whole move towards integrated care systems, I think, has been welcomed nationally across the NHS. Next one, please, Anna. So final slide, just in terms of process, we've got the merger vote through. Our understanding at the moment is that there are likely to be in-year mergers from the 1st of October. We've not had that formally confirmed yet, but that's what we're working towards. The default position would be merged from the 1st of April, but we're working very much to a 1st of October merger process. We are also looking to have a panel. NHS England will convene a panel to review our merger application. I think it's on April the 26th. What we're doing at the moment is listening to the views of stakeholders and the public before we make our formal application to merge by the end of March. We're looking to get that in on the 26th of March if we can. But given that, as Simon said, the white paper was published in February, and the legislative timeline means that there will be the legislation will be drafted, I think, in April, and will have its first reading in May in the House. Yeah, we do need to get that application in, and we do need to get the application approved by NHS England so that we can continue working with the system partners on everything else we need to do over the course of the year. So we work with system partners on that, and as Simon said, it will be, whilst a lot of the focus has been around CCGs and also changes at NHS England on the commissioning side. There's an awful lot around how we actually, within Staffordshire and Stoke-on-Trent, within the ICS, delegate some of the responsibilities that the CCGs currently carry out to our provider partners through the ICPs, and we'll be working on that over the course of the next 12 months. There's some other areas as well that we'll be working on around the strategic development. We need a clinical commissioning strategy, again agreed with system partners, which we will develop over the next couple of months. There's an HR process. Clearly, a lot of staff will be affected by this, CCG staff, NHS England staff, and also commissioning support unit staff. There is NHS England have given a continued employment promise to everyone below board level that is good into the next financial year, which is April 22-23, so that the vast majority of the staff delivering functions within the CCGs and NHS England that will still be needed in an ICS, and we want to make sure they feel able to sit tight whilst this process goes on and don't have concerns around having a job in the future. We will also need to recruit to a single governing body, going from 6 down to 1, a chair, senior leadership positions. Further guidance on that will be issued in the next month or two, and also a new clinical model, because CCGs are clinically led organisations, and whilst we go from 6 to 1, we want to ensure that remains the case. So I wouldn't underestimate just how much work we have to do over the next 6 months to prepare for merger in October, from 1st of October. But after that, in terms of creating a new integrated care system, and anything that we do for the CCG merger, we need to be minded for what we will need in place from the 1st of April for an ICS, obviously subject to the legislation being passed. So a pretty significant piece of work, which we cannot afford to distract us from the important business of managing the COVID pandemic and getting back to business as usual as we restore services, and also the delivery of the vaccination programme. So I'll probably, I think there's a next slide which I think is opening up for comments, but I'll pause at that moment, Chair, and happy to take comments and questions.
Thank you. Before I go into that, Jonathan, can you just refresh my memory on two things, please? First of all, we're being asked to provide feedback on the proposals on the ICS. Is that correct?
That's as I understand it, Chairman, yes.
Thank you. So this is the point I'm making. This is about stakeholder feedback. And second of all, I believe that when the actual merger proposals for a combined CCG came in front of the committee back in November 2019, the committee was in favour. Is that correct?
In principle, Chairman, I think they were.
Thank you. That's helpful. Let me open up to Charlotte Atkins.
Thank you, Chair. Just a couple of questions. In the paperwork we had distributed before the meeting, under financial equity and risk, it talks about by becoming a single organisation, we will be in a better position to access transformative funding. So I just wondered what sort of funding we were talking about, number one, and is this a new pot of money? And secondly, presumably integration is all about improving the experience of the patient and ensuring that their journey is more appropriate to their needs. So I want to give you a case, which is a real case, but I'm not going to mention the gentleman's name. Gentleman went into a care home for respite care, and while he was there, he had a fall. He was suffering also from dementia, so he went into Good Hope Hospital. And he had fallen several times at home before then. And then the care home where he'd been for respite care wouldn't take him back. So he stayed in the hospital, and he stayed in the hospital, and he stayed in the hospital. And now he's languishing in Heartlands Hospital. So this gentleman is 87 years old. How would his journey be improved by this integrated care system? Because it doesn't seem to be appropriate that a gentleman who went into a care home for a couple of weeks of respite care is now in Heartlands Hospital, and it appears not going anywhere. So those two questions, please, if that's possible.
Who wants to pick that up?
So if I make a start, Chair, thanks, Councillor Atkins. Let me deal with the second one first, but equally I'm sure either Dr. Hannigan or Dr. Bradley might want to come in and join in this conversation as well. I guess the starting point for me would be we know, irrespective of an integrated care system or not, actually, we know that we want to keep people for a shorter time in hospital beds as possible. There's really clear evidence about the deconditioning that takes place, about the impact in terms of the loss of independence and everything that goes with that. So I don't want to talk about an individual case because I don't know any of the clinical background and wouldn't want to get involved in those bits. But the principle should always be, which you said right at the start, Councillor Atkins, how do we make the resident's journey through the health and care system as effective and as quick and as timely with the correct interventions as possible. Now, I don't think you need necessarily an integrated care system to be driving that. But I do think we need to be making sure that we use the approach to develop the integrated care system to break some of the barriers down that have got in the way at times. But it's not going to be perfect overnight. But I would agree with you. We absolutely need to get to a point where that flow and that journey for the resident is about getting them to the right place as quickly as possible with the right package of care around them. And more often than not, we would want to keep residents in their own home or their normal place of residence for as long as possible and as safely as possible with the right services, and use the hospital bed for an intervention, and then get them back out of that hospital bed as quickly as possible. But Alison, I'm not sure if you want to add to that.
Thank you, Simon, and thank you, Councillor Atkins, for your question scenario there. I think you've very eloquently summarised probably what I was going to say. I mean, I think the main thing I would say is this is about working together as a system on an integrated care system level across health and care to set those outcomes and the priorities of what is going to be the best outcomes for our population. And I think then it's about sort of how we deliver that on a local level through our integrated care partnerships, and further down to a neighbourhood level is how we then deliver those services, because they will need to be local nuances to how those services are delivered, and also the needs of the local population. So again, for me, it's about planning those pathways based on the priorities we've agreed, and working together across all those providers of care, and actually recognising some of that, again, that really starts with the patient and improving and maintaining that independence and, you know, degree of self-care and the carers at home, really, and then how we then wrap those services around them. So it is very much about working together, and I think we have, colleagues on the call have already sort of articulated how important and how much we've seen with the response we've had to rise to the COVID situation, how we have worked together to respond to COVID, and also to deliver the vaccination programme.
Thanks, Alison. And then Councillor Atkins, in terms of your first question, I think not necessarily new pots of money in terms of the finance one, but increasingly the national process for sharing out money and allocating resource into local areas is through systems. And so they're coming down, so capital money is coming into the Staffordshire and Stoke-on-Trent STP as a system, and no longer in the smaller individual pots. So the line in the paper work there is around just aligning with the national allocation process for some of those additional resource that doesn't come down as the core allocation, just to make sure we've got absolute clarity, absolute transparency, and can demonstrate that really clearly.
Charlotte, do you want to come back?
Yes, just very quickly. I mean, the point I was really making is that we might well talk about integration. We might be talking about working better together. But if the service is not there, and, you know, we're talking about here someone who is frail, who's got dementia, and there's nowhere for him to go. And all this integration and working together is not going to make a difference to that, is it?
So
you know, unless there's a place for him to go, unless the services are out there, and, you know, for all the best will in the world, there is a lack of facilities for someone who's got both a physical frailty and a dementia issue, and there is nowhere for him to go. Now, that's why he's stuck in hospital. Now, it seems to me that unless we get to grips with the needs of an elderly population that sadly is increasingly going to get dementia, all the integration in the world is not actually going to resolve it. So while we're faffing about with all sorts of integration, okay, I am interested in the journey of the patient. And so far, I have not yet had reassurance that that journey is going to be any better at all under this new system.
And I think that's a really fair challenge, Councillor, and I'm more than happy for us to keep coming back, and when we come back to, or indeed separate to the meeting, Chair, to talk through some of the work that's happened over the past 12 months around the care home flow, the pathways around that, the changes that have happened. You're right, there's still going to be times when we get it wrong, Councillor, when the system doesn't work for the individual. And what we've got to keep doing is keep learning from that and getting better, because it has to be about the residents' experience of care.
And with a £9 billion cut in NHS funding, that's not really going to happen, is it?
So we have to make sure we use every single penny that we get as effectively as possible as we can against the backdrop of constrained finances. No different than the council has to make really difficult decisions around its services with the budget challenges that it has.
Yeah, exactly. Budgets are key. Thank you.
Thank you, Charlotte. Anne Edgeler, please.
Thank you very much, Chairman, and thank you for your report, Simon. Can I just ask, on page 8 on our agenda, mental health is a growing problem within the community, as we know, and COVID hasn't helped. But you do say that you're going to treat mental health the same as physical health. Can you tell me what you intend to put in place to help that mental health move forward with people and all their problems? My second question is, you say about the place-based partnerships and where they're going to be placed, one in the north, one in the southeast and one in the southwest. Whereabouts are those going to be? And that's my second question. My third question really is, on page 9 of our agenda, you talk about the commissioner. How is that person going to be chosen, and who's going to decide, who's going to be in place in that position? Thank you.
Okay, so thanks, Councillor. I'll let Marcus or Alison come in to deal with the third question, if that's okay. In terms of the first one, I mean, the starting point is a really important principle, which is mental health needs to have parity with physical health, and previously it hasn't. So the Mental Health Programme Board, that's led by the mental health providers across Staffordshire and Stoke-on-Trent, is bringing a real focus to how we use the transformation money and the resource that's in there to offer the services to the local residents. But we also know, as you flagged, Councillor, there's going to be there is an ongoing significant increase in demand as a result of the COVID pandemic, whether that be the impact from on the economy, the impact on loneliness, on isolation. All of those are contributing towards the mental health challenge that we're going to face in our system. And that Mental Health Programme Board has that as a real focus. But there's a principle which you've got in your paper, which is about the parity of esteem around the mental health provision and mental health services versus the physical health. And again, that's not always been to that level, and we've not always got that right in the past. And I think when Peter Axon came last time and Neil Carr was on the call, they both talked around the work in terms of service development that they're doing jointly to try and meet that increased demand and increased need that's coming through at all levels, from severe through to some of the lower level intervention and support around that as well. Your second question then was around, just remind me, Councillor, what your second question was. Your third one was around the commissioner. The second one was
ICPs.
Yeah.
So really, roughly, and there's people that can probably do the geography better than me. But the north one is North Staffordshire and Stoke-on-Trent. So Newcastle-under-Lyme, Staffordshire Moorlands, Stoke-on-Trent, and captures that area because of the relationships and the flow of activity and pathways across that part of the system. In the south east is the Burton patch with Lichfield and Tamworth, and then in the southwest, and somebody's going to tell me if I'm getting the geography correct here or not. And then in the southwest is the south part of the patch that borders with the Black Country and includes Stafford and surrounds. So it's a loose boundary, but it aligns with some of the local tiers, districts and boroughs, as well as then with Stoke City Council in the north. Marcus, you come up on the screen. Is that?
Yeah, no, that's right, Simon. So effectively, it's sort of, for the southwest perspective, Stafford, Cannock, Rugeley, this eastern peninsula. The point I was going to come on was, whilst there are geographic boundaries that we draw, we divide Stafford and Stoke up into sort of the three patches. over half of our, about half of our acute activity goes outside of Staffordshire. So there's also the issue around how we work with neighbouring areas. Sort of as Simon said, and using Councillor Atkins' example, Good Hope is not actually in Staffordshire, but a big chunk of our patients from Lichfield, Burntwood, etc., go to Good Hope for their care. Likewise, majority of our patients in Cannock will go to Royal Wolverhampton Trust for their care. So we're not an island as an ICS or ICP. So that whole issue around managing cross-border flows, working with neighbouring patches, making sure that discharge pathways out of Good Hope, out of Wolverhampton for people who come back to Staffordshire work well for those patients. So just some assurance, I guess, that we're not looking inward, we are actually looking at how we engage with our neighbouring systems, which will be absolutely key. Because if you take the Seaston Peninsula, for instance, patients hardly like to stay within the peninsula for their care. They will go to Dudley, to Walsall, to Telford for their care. Shall I just pick up the commissioning one, Simon, and Chair? So one of the things I very briefly alluded to when I did sort of my couple of slides was around the senior appointments process. So we are expecting guidance on that, I think in April, around what we do around that, and clearly going from 6 CCGs to 1, there will need to be a process for appointing the single accountable officer for the 6. And there's also the assuming the legislation's passed, there will be an ICS chief executive as well that will need to be appointed to. The process for that will be set out in the guidance we get in April. Very happy to come and talk to you about that. So we are awaiting that, but we know that there will have to be a process for making those senior appointments. As I said, the continued employment promises for board level, below board level. So Paddy, Alison, the 6 chairs, myself, Simon, my exec team, there's a whole raft of people, NHS England colleagues as well, delivering roles that will all be sat there eagerly waiting the guidance in April to see what happens to us over the course of the next 12 months.
Yeah,
nicely navigated. Do you want to come back, Anne?
I'm just concerned that nobody gets lost into the with the system, and everybody gets the care that they really need. And that's why we're asking the question: where are these place-based people going to be, and where they're going to be situated within Staffordshire? So thank you for your answers, and it'd be quite interesting because whoever gets that job is going to have a real powerful seat and be, what decisions are going to be made in the future. So thank you for that. We'll keep an eye on that. Thank you.
Thank you, Anne. Bernard Peters, please.
Thank you, Chair. I looked at page 13 of this document and I was anxious to see where risk got a mention. And I'm not too impressed by the way it's been framed in the paper, because there are several things that to develop a risk management arrangement, I'm mindful that it aligns with the BAF, I think, from one of the bits I've been reading. Risk, unless you ensure you get this right at the outset, the generation of a risk-based culture in the leadership, let alone the guys who will be delivering it, you need to understand the values, the beliefs, and the understanding to be able to make this system operate. So I wonder if you could, it's a hell of a subject, this, isn't it, really? But there must be something in there that you can provide assurance on, because the management of risk, effective risk management, creates opportunities. So that's always a good thing for being able to move forward. And I wonder if you could say what weight you give to this process in terms of lean working. I would have expected to have seen some mention of lean. It's, change management comes lean working. So I'm sure it's in there somewhere. And the final question, in 12 to 18 months' time, what will good look like?
Yeah, so there's a lot in there, Councillor Peters. In terms of the risk element, I would I'd ask Marcus and Alison to pick that up, because I think that's more focused on the risk register that supports the CCG merger, because that's the main focus of that conversation. But really quickly, in terms of picking up what good looks like, would be Councillor Atkins telling her story and saying there was a very different outcome for the gentleman and the individual. So I think let's go back to it's about the best outcome and the best experience for local residents. That's for me what good would look like.
Okay.
Yeah, so Chair, I guess, yeah, the two key elements of any business are controlling costs and managing risk. So we do put an awful lot of focus on risk management. So we do have the board assurance framework, we have our risk registers, and we take that really, really seriously in terms of putting in place the appropriate sort of controls and mitigations. I think we're probably working through the riskiest, certainly in my 30 career in the NHS, probably the riskiest period we've ever been in. And yeah, it's not lost on us, and it certainly wasn't lost on the membership, asking them to vote on merging the CCGs, creating a new integrated care system in the middle of the biggest challenge the NHS has ever had to face in its 70+ year history is not ideal. What we've tried to do is identify obviously risks around the merger process, but then broadly the ICS will inherit, the single CCG and the ICS will inherit a whole raft of risks that will need to be adequately managed over the coming years. Our financial position, clearly we're as a system spending about £200 million a year more than we get. So our financial position, which is a key priority, will need to be managed over the next 4 or 5 years without having a negative impact on patient care. We've got risks around delivery of the NHS constitutional targets will need to be managed, around our urgent care system, around plan care. We have massive backlogs of care that we will need to work through, which will put a real strain on NHS and independent sector capacity as well as our budgets. So I think there are risks around the merger, but that sits within a much broader panoply of risks that collectively as a system will need to manage. I think one of the benefits of an integrated care system is that we share those risks rather than try and deal with them on our own. One of the problems we've had in this system, in common with other systems, is if you want to manage your risk, you try and pass a big chunk of your deficit onto your system partners. Your position might get better, but the system position doesn't get any better. So it's something about the NHS organisations working together collectively, also with local authorities, to how do we best share this, spend the Staffordshire and Stoke-on-Trent pound once between us, rather than trying to shift our problems onto our system partners. So there is a huge amount around sort of managing risk and controlling costs that I generally believe we're in a much better position to manage if we do it collectively through our integrated care system than trying to do it individually, where organisation imperatives often trump the wider system good, and quite often patients get stuck in the middle of that as we argue around sort of who pays and who picks the cost of that up. In terms of your question around lean, clearly we try and work as efficiently as we can at all times. There's no specific mention of lean. For people who are not familiar with lean, it was developed by Toyota, and it's something that's been used widely across many areas of care. I think we have some work to do around efficiency more generally. I think an integrated system where you do things collectively rather than separately will help us become more productive and more efficient. But I'm not going to say for 1 minute we're where we need to be on that. There's an awful lot we can do better. That will be obviously a priority over the next 3 or 4 years as we try and become more efficient, take out costs and deliver better outcomes.
Bernard, do you want to come back?
Yeah, thank you, Marcus. To me, that just focused my mind on the importance of the leadership team, because they'll be managing the people, they'll be motivating, encouraging and pulling them back up the well if they feel as if they've been abandoned. So, yeah, I feel reassured by what's been said, and thank you, gentlemen, for that.
Thank you.
Thank you. Let me just ask a question, if I can, please. It also sort of relates to the page 13, financial equity and risk. I guess if I was a district or a borough, I might be concerned that some of the money that's currently spent, on my residents or the residents in the area that I represent might be diverted elsewhere. Or if I was, taking services from one of the existing CCGs, then they may see diminution in finance. What reassurances can you give residents of Staffordshire that they'll still be able to access the services that they need?
Yeah, if I could maybe pick that up. So one of the key challenges that we had in terms of assuring our members around voting to merge and create a single strategic commission was the right thing to do, was around the allocations, both allocations and debt and deficit, accumulated historic debt and deficits. The CCGs all get different allocations based on a national funding formula, which takes into account a whole raft of things like deprivation, age, geography. And there is a gap, there's a difference of around about £200 per head. So the average allocation for the CCGs is about 1,000 for last year was about £1,580. Stoke gets about £200 more than East Staffordshire, which gets the least based on that national funding formula. If you look at the deficits across the CCGs, whilst everyone is in deficit now, certainly when we asked members to vote in 2019, that wasn't the case, where East Staffordshire had a small surplus. So I think the financial position across all 6 CCGs is sort of not dissimilar. What we will do, though, as we move forward, is look to preserve some of the way that the national funding formula is used to set the budgets for the ICPs. So each ICP, based on the national funding formula, will be delegated a chunk of the CCG's resource. We'll do that in shadow form for next year, and then the ICS will pick that up then in real terms from 2022. We're confident, based on the work we did around for the 3 ICPs, the funding formula and the way we will actually allocate budgets. I think we're assured as we can be that will reflect need and ensure that each of the ICPs has a fair share of the total pot to commission and deliver care for its population. But as I said before, all of our CCGs are in deficit. The CCGs around about £150 million. Underlying problem, the providers around about £50 million. So the 2.7 billion that we spend across the system, if we don't do something about that, we will continue to spend more than we get, and our underlying position will get worse. So the allocation issues is really important to make sure the money follows need, but also we are going to have to do a lot of work with system partners on spending, living in our means, and probably through managing growth rather than reducing spend. We do have a financial strategy that we're working on with system partners at the moment, which we'll put in place over the next 5 years. But I wouldn't want anyone to be under any illusion. It's going to be incredibly difficult in a post-COVID world to meet the needs of our population, reduce waiting list backlogs, and also live within our means. It will be a real challenge. But allocations will use the national funding formula for the next few years. But we're still spending a lot more money than we get, and that's going to have to be the focus.
Thank you, Marcus. Charlotte, is that a legacy hand?
Yes, sorry, it is.
David, let me bring you in, please.
Chair, sorry, I'm really sorry, but I needed to leave at 15:15, so I stayed on for the questions, but I'm going to need to leave now if that's okay. I'm really sorry.
That's okay. Understand the timings, and we need to bring this to a close. But let me just, Simon, thank you for inputs today. We'll let you know what the committee is going to recommend. But let me just take the last question as well. But thank you for attending.
And apologies for leaving midway through the session.
Okay, thanks, Simon. Marcus, you might be able to field David Latham's question, or Alison might be able to. David.
Thank you, Chairman. By sheer coincidence and probably misfortune, I've just received a text asking for help. A chap's got his sister-in-law, who's in her 60s, I believe. Looking at the text, she's got at least 8 separate health conditions, all of which can and probably will kill her. The problem is, and I quote him, we can't find anyone to treat her for everything. She's being treated by so many people for separate issues that she's on 36 tablets a day, and she's in a terrible mess because nobody seems to understand how to put her into a package to be dealt with. Everyone's treating her conditions separately. And here we are talking about integrated care system. I know it's a difficult one, but can anyone please give me some help as to what I can suggest this guy can do to make contact with someone who might be able to help him?
Alison or Paddy, would you like to maybe pick that one up in the first instance?
Yes, I mean, again, I think it's difficult to know, obviously, on an individual basis, what that individual's needs are. But I mean, I think in terms of in terms of primary care and the GP, every resident of Staffordshire and Stoke-on-Trent are registered with a GP, and that's really sort of the focus of where all the health information is held. But now, luckily, with the integrated care record, which has been rolled, Paddy knows all about, has been rolled out across Staffordshire. That everybody now has a much more robust and informative care record, which can be shared with everybody involved with their care. But I mean, I think in terms of the first port of call, I think it would be I think it really would be with the GP first and foremost, really, but then actually understanding all the elements of all the individuals that are involved with the care, and actually then finding a forum, for example, an integrated local care team or a multidisciplinary team meeting, to actually for all those professionals involved in the care to actually work together to understand what care is involved, what the individual, what that patient needs, and actually what the gaps are in the care and how it can all be pulled together and coordinated. And I think really going forward, this is I mean, and this highlights, you know, a very sadly, you know, too common case of where care isn't coordinated, and really in terms of, you know, what good looks like. Care needs to be coordinated for the patient, so we deliver the best care, but also the most effective and efficient care as well, within the resources we've got. So I don't know whether that helps in terms of maybe that for that individual to first of all probably go to primary care first, to the GP first, and then but to understand everybody, all the individuals that are involved in that patient's care.
Thank you. Yes, it gives me a framework that I can suggest to him, and especially if he uses words like multidisciplinary team meeting, the GP may think, oh, he knows what he's talking about.
And I think also going forwards in terms of how particularly primary care are working and how we're working within primary care networks, there are lots of different sort of different ways of working and different specialities that are coming into that primary care network way of working. Sorry, such a
the marvels of technology.
Sorry. But so, for example, working with sort of social prescribers, clinical pharmacists, physiotherapists. So again, it's all about how we need to tailor the needs of the patients to the care that's available.
I think what it's illustrating to me is that the patient's family needs to know the ropes in order to get the job done. I'm not being cynical. I think it's just
and I think we need to build in very much. We need to give carers and individuals the resources and the knowledge, and share all that information. So, that, for example, care navigators, social prescribers. It's about pulling all these resources together so we can direct patients and carers most appropriately for the needs of the patient.
Thank you, Alison. I'm going to jump in there and try and bring the conversation back to ICSs, if you don't mind. I think it's a useful demonstration of the complexity within the system. So, David, I hope you don't mind me just taking back Chair's license.
No, absolutely. Thank you. That's been very, very helpful.
And I'm sure if you need anything further, either Marcus or Alison would be more than happy to help, not necessarily get involved in the personal basis, but to give you some ideas. So the purpose of the report, the purpose of the discussion today, I noticed there are no more hands. The purpose of the discussion was to provide feedback on the direction of travel and the proposal to become an integrated care system. I think we've talked a lot about some of the pluses and minuses today. We've seen this before. Can I make a suggestion in terms of what the formal response from this committee could be? And then you can tell me whether you're in agreement or not. First of all, that we note the proposals and the support of the membership body, that's the GPs, and we look forward to seeing more detail going forwards as that is developed, and we look forward also to seeing improvements in patient journeys and outcomes. Is that a reflection of what I think we've discussed this morning? Can someone just say yes or no, please?
Yes, Chair, I agree with you. Yeah.
Are we all in agreement? Anyone who isn't in agreement, just throw their hand up. David, you've already got a hand up, so you need to take it down first, please. Thank you. Anyone who is not in agreement with that response, can you just indicate by putting your hand up, please? Thank you. Let's move on to the thank you to Marcus. Thank you to Alison. Nice to see you again. And obviously, thank you to Simon, who's had to go, unfortunately. Can I suggest in... Sorry.
Thank you. Bye.
Can I suggest in terms of agenda, I know that we're in real danger of losing Richard. Do you want to take the care homes, item 7 next, Richard?
Chairman, Dr. Harling has actually left the meeting, so
Fine.
it's going to be fielded by Helen Trousdale.
That's brilliant, in which case we'll keep with the original order then, if you don't mind, Helen. So on to item 6, Together We're Better digital programme update. Who's leading us through that one, please? That's Stuart Lee, Chairman. Stuart, most welcome.
Hi, Chair. Thank you very much. If you just give me 1 second while I'll just share a slide deck with you. Obviously, Paddy's had to leave. Paddy would have liked to join me on this, but has needed to take another call. Excuse me. Can you see a slide deck there? Yeah, mine's just, there we go. Have you got that?
Not yet. I'm sure it will come.
Yes, I've got it.
Have you? Okay. Well, I'll, as the majority of members got it.
So high, yeah.
Yes.
Right. Please carry on then.
Okay, I'll prattle on. So what I guess in the interest of time, what I just aim to give you is an overview of where we've got up to the digital programme across the STP. And then in particular, I guess kind of your real ask was how's COVID affected that and what difference has that made? So I'll dwell a little bit on that during the slide deck. I've pre-circulated a paper that gives you some background information on this, so an opportunity for questions throughout this. So in October 2019, we updated the digital strategy and based that around about 6 key pillars across the STP. I won't kind of delve into any of these in any detail, but top left there we've got our empowered patients pillar. This is probably the most exciting one that we've got and probably the biggest step change in health and care and digital services across the patch. So this is all around about how we actually connect our patients and our citizens back to health and care services digitally. As I say, real step change, anything from kind of apps and self-care right through to remote monitoring and capabilities such as that. The top right box is around about digitized care. I kind of describe this as getting our own house in order. So basically making sure that we're capturing stuff electronically and making sure that we're sharing it with appropriate people, and then going that next level and kind of introducing things such as artificial intelligence and starting to drive that agenda. You've probably all heard of population health and in the middle left box. So the ability to actually take our data and use that on a much greater level, starting to join that up across the system. Excuse me. Starting to join data sets up and starting to get real insights at either at kind of holistic system level and right down to patient level so that we can start to drive the agenda through information. Middle right, around about infrastructure, predominantly a kind of a boring necessity, but making sure that we've got the right levels of infrastructure in place, cyber security, all of the kind of unseen stuff that needs to happen to make digital work. Kind of two critical bits at the bottom there. I think certainly bottom left around about not just our own capability and our leadership capability, but also our ability to innovate across the patch. So, you know, it's not the same old. We need to think differently, and we need to be in that position to innovate. And then I've certainly heard a lot this morning around about boundaries and kind of not having boundaries within care, and that's one of the things that we really aim to have, not just internally across the STP, but also outside of that and into our neighbouring areas and beyond that. So really, let's break down those boundaries. Let's treat digital almost like the organisational boundaries don't exist. Let's focus our digital efforts on the needs of the patients. There's a whole programme that sits behind this. And we kind of kicked off some of that work in October 19, aligned to the strategy. And then obviously March 2020, COVID came along. Almost overnight, COVID scuppered what we were trying to do, but equally it really kind of empowered some of the things that we then did after that. And I won't talk in terms of what COVID did. You know, you all know what happened and the kind of instant need to do things differently. Some of the key threats that we had around about potentially not being able to see high risk patients, people being locked down in the homes, etc. Health and care services quite clearly needed to continue. We couldn't stop doing that. So almost overnight, we empowered 25,000 plus staff to work from home. That in itself sounds, on the face of it, sounds simple, but when we need to make sure we've got access to all the correct resources and that people can do the things that they need to do, that was quite a test. But as I say, you know, not quite overnight, but certainly in a very, very short space of time, empowered people to work from home. Deployed Microsoft Teams, and that in itself, I think, you know, we're obviously all sat here on Teams now, and I noticed that at the very start of this chair, you kind of outlined some of the culture of Teams, and that's really been developed by it's kind of grew organically. Nobody's really turned around and said this is how we run these things, and that is a factor of people's engagement in the technology that we've put out there. Some fairly major procurements, and some of these things went, you know, literally within 2 weeks. There were national procurements for virtual consultation technology. So we've gone from people traditionally coming into practices and into hospitals for appointments to actually a scenario where we've got, in many cases, 70–80% of appointments being done remotely, certainly from a first appointment perspective, and therefore only kind of needing visits where they were particularly required. I think certainly kind of following up on that, there's work to do in terms of getting that right, and we absolutely know that. But feedback generally from patients is really positive about the use of remote consultations. Things like COVID dashboards, you know, really important that we've got the information, and we've heard Paddy, we've heard Marcus talk around about some of the information on COVID, some of the stuff on the vaccinations. All of those dashboards had to be developed and pretty rapidly. Some of them we almost kind of moved after that initial phase. We moved then more into how we make this stuff more embedded. So then dropping more into things like remote monitoring of patients. These, I guess, you know, operate on many different levels. Anything from trying to avoid admissions in the first place by giving people technology to simply monitor themselves at home and either share the readings or you know, kind of go by a crib sheet to decide what's good and what's bad, and as they hit a certain level to start to self-escalate. Right through to kind of technology that sits in care homes, so that we can actually remote monitor patients in care homes on a clinical level as well as a care level. We've heard an awful lot about vaccination services this morning. I wouldn't underestimate the digital challenge with enabling all of that. So in many respects, a kind of a difference in what they would prefer the national approach and how the operational side of that works. So digitally, we've got national systems that manage vaccinations, we've got local systems, and in a space of probably about 4 weeks from clarity of when some of the vaccinations would kick off, There's been integration between national and local systems so that we've got genuine vaccination data going around the system. We can call the right people at the right times and keep some of that stuff updated. I'm not going to claim that's perfect. I guess as with much of this, it's not perfect, but it's been done rapidly. I would add to this, all of this has been done, and I think the way that people have engaged, and when I say people, I mean the whole stakeholder community, anything from the staff who are doing this right through to the patients, the carers, the people that are out there helping. All of this has been done with very little hands-on help. It's just been dropped on people, and most people have picked up and run with that. So I think there's some kind of real positives that we've seen in the wider engagement to this. Key things about lessons learned. I wrote a paper on this probably 7 or 8 months ago now, fairly early on, and it was almost, we were kind of giving ourselves a little bit of a pat on the back in terms of what we've achieved in such a short space of time. There's almost kind of 4 key characteristics around that are absolutely not sustainable, in the sense of that there was this burning platform. We instantly had polarized priorities, and it was amazing what we could achieve once those priorities were properly polarized. And I think, you know, we all work to common priorities, but actually when they're really focused down and we're all pulling together for the exact same thing, we can achieve massive things in a very short space of time. Really, really strong leadership across that patch. I think digital leadership is it's an interesting beast, and I think it's interesting when we look at the whole of our leadership community. You know, clinically orientated. It's all driven, so it's all fantastic stuff. But some of it was kind of dropped into digital leadership as well, and what we achieved, because we had genuine sponsorship from the very top to make things happen, was rapid. And then to add to that, I think national support was the other one, and actually nationally, the NHS as a whole were more than willing to take some risks and make some stuff happen, all of which was really good. As I say, these conditions are clearly not sustainable. We wouldn't want to sustain them, but I think it's really important that we pick off some of those key themes and start to learn some lessons in terms of how we apply stuff going forward. I'm certainly not going to claim that everything was perfect, and still isn't perfect, because I think the pace at which some of this was rolled out has meant that things weren't done probably in the most optimal way to start with. We're probably still in a scenario where this is not normal. We would like to get some of this stuff into normal, but I think part of this is making more of a judgment on what normal is, how many people we should see remotely, whether we should actually triage people before we do that. So there's lots of questions that we've got in terms of how do we make the best of this technology, but what a platform to work from that we've got. One of the things that I've mentioned this a couple of times, I think that the tolerance of stakeholders was extremely high. That may be that is not sustainable, and that people actually, the tolerance will start to drop. Because of the scenario we were in, and I think we've seen that tolerance across the country really on a whole range of things, not just ability to engage digitally, but that is really there. I think some of the innovation and the staff-led learning was really high. I think what we can't do is get complacent. You know, we can't miss out on things like digital literacy to make sure that we bring people along. Digital inclusion, again, you know, this is not all about let's make everything digitally, and I always stress that when I talk to anybody. This is not an either or. This is about supplementing what we do with digital services. The biggest single risk I think we've got is that we've made a massive amount of progress, and actually we just need to be careful that we don't slip back into old ways of working, and we need to be careful that we don't almost view this as too much of a good thing. So as with many things in life, it's about achieving the right balance between what we do digitally and what we do in the ways that we used to do them. I think the long term digitally, I think, you know, a key message is COVID is here to stay, and we've heard about kind of continued vaccination programs into next year. If you talk to GPs and clinicians, you'll kind of get conversations around about how we manage patients going forward, how we're bringing patients in at the right time, and how we minimise the risks. So we've got things to do, and I think certainly for us, you know, digitally, supporting the vaccination programme. You've heard Marcus say that things are improving, and I think he's right. I think we probably need to add to that and make sure that we continue to improve the digital side of the vaccination programme. and then get use of virtual consultations right. I've seen numerous statistics in terms of the percentage of consultations that are virtual. I think it's fair to say that it's not right for everything, and we need to try and pick and choose, perhaps via a triage route, exactly which are most appropriate for virtual consultations in the first instance, and make it patient orientated and patient centred going forward. Long COVID, you've probably heard lots about long COVID, but I think for us, there's the key digital interventions are about remote patient monitoring, so that those with long COVID aren't necessarily using the beds up. Actually, we're kind of keeping people in the homes where they want to be, but actually making them safe so that they've got that reassurance around them that their conditions are being monitored remotely. They can share readings, anything from once a week right down to 3 or 4 times a day, and be assured that that's going into a system and being managed. I think supporting that is kind of population health management and data analytics. So actually understanding what we mean by long COVID, understanding what the implications are. And that's not just about use of Staffordshire data, that's about working with partners across the country really to do some kind of long-term mapping and understanding of that. Obviously, you'll have heard, and I think we're kind of close to breaching the 52-week waits in a lot of the country. I think the growing waiting list, the challenge for us digitally, and the questions that we're starting to talk to clinicians locally about is how can digital start to help manage this? Waiting lists are waiting lists at the end of the day, and if they require a physical intervention, then it makes it difficult for digital interventions. But the challenge for us is how we try and support that. So we're having those conversations now. And then finally, this kind of growing and somewhat unseen demand across primary care. So I've seen, again, numerous statistics around about the drops in primary care appointments during the period of COVID, and then the kind of ramp up into remote care. But what is it we've missed? What's gone on within that time period where people chose not to go to the GP practices, for all of the what they perceive to be the right reasons to keep the burden down on the NHS. It's important that we try and capture that. Some of that is around us doing some predictive analytics, doing more with risk stratification and more trying to proactively identify patients, more on the patient empowerment front and self-management. And then again, kind of trying to manage the demand through that online digital triage and use of AI going forward. On a wider footprint, I guess outside of COVID, we heard Dr. Bradley talk about the integrated care records that was launched in August last year. You can see the partners to that. What we've done is start to bring together all the records of all those partners so that all clinicians within our system, all care workers within our system have got that holistic view of the patient and can start to wrap and build the care accordingly around about that full view. Supporting that, we've put in information governance to support that information sharing across the patch. And we've started to build links into what was formerly called the LICRAs or are now called the shared care records. So these are the national versions of what we've done. So we're starting to plug into that so that boundaries and certainly kind of large crossover areas, Wolverhampton, Walsall, we've heard about Market Drayton this morning, really starting to make sure that people across those patches have got that same level of holistic view. And then a kind of little bits in terms of the text programme that Ruth's been leading on, and then wider reviews that we're progressing through.
Stuart, I don't want to lose the opportunity for questions. I know you've got a couple more slides. There's a lot on those slides. Could you just give us a couple of minutes summary just to bring your presentation to a close, please?
I can indeed. Excuse me. I've literally got 2 slides left. I think one I'll leave you for information because it's a detailed overview of this year's priorities. In January this year, we agreed that the kind of key priorities for the digital programme. I won't delve into it in any detail, but at the centre of that is anything that drops out of COVID that isn't specific on there. The use of NHS app. At the top left, this is around about creation of a single routing to all the digital services that we can promote locally. Top right of that is our links into the local healthcare records, so that wider sharing beyond Staffordshire and making sure that we don't have those digital boundaries. Creation of population health management, and specifically making sure that we've got the right data for that. And then at the bottom right there, and I guess it kind of talks to some of the points that we've heard, is tools to really empower that integrated care plans. So this is now around about wrapping a single care plan around about individuals they're not unique to any organisation. What we've got is kind of one care plan around the needs of the patient, rather than multiple care plans that are focused around about the needs of organisations. And then just underneath that, we've got 3 key areas that we want to focus on that we've not necessarily got defined plans in place for, but are absolutely paramount and centric to what we do, and that is the remote monitoring and remote care agenda. Really kind of seeing if we can empower care homes going forward and moving them onto that digital footprint in terms of what a blueprint looks like and kind of digital maturity, and then the wider upskilling. I won't talk to this slide, but this slide is some of the key projects that are supporting those priorities, but I'll kind of leave you this as a takeaway, and probably just leave this on screen actually whilst we're open for questions.
Thank you, Stuart. So lots in there. Maybe we could take the slides down so that individuals can get on screen. We've got copies. We've got copies of the slides in any case within members' packs. Kath Perry, can I invite you to the floor?
Yes, thank you very much indeed, Chairman, and thank you, Stuart, for your presentation. There's an awful lot to take on board in that presentation, Chairman. I'm sorry, I think we could have done with an whole morning actually just to discuss this item, if I'll be quite honest with you. I mean, there's so much under all of those headings in there. I'm frightened that we're going to leave some people behind in all of this. It has always been a fear of mine. We're moving too quickly on this. What we've heard this morning from other departments, the one CCG, we're now going into this your digital. And I think we're going to be leaving a lot of people behind in all of this. They're going to get lost. I myself can't take it all on board, if I'll be quite honest with you, what you're trying to tell us this morning. So I do think, Chairman, that there should be an opportunity for us to actually go into this in more depth, if that's possible, on this particular subject. I'm not quite happy with some of the things I've seen on there, if I'll be honest with you. I'm not hearing that on the ground locally in my division about digital and about using the phone for discussing what's wrong with people. I'm not hearing very good reports on that, if I'll be quite honest. So where you're getting your information from, I don't know. But I know in my division, I get lots of people say to me, they can't get in touch with anybody at the GP. They're listening for the first 10 minutes on choose this or this or this on the telephone. And I think we're differentiating. Yes, technology is good and it is the future, but I want to make the point that I'm frightened we're moving too quickly down this route, and I'd like to see more of what's going on with this in this particular presentation, Chairman. Thank you.
Stuart, before you answer that, can I just sort of cut that sort of questions set of questions up? So first part was about the concern on the speed and leaving people behind, and in which case there must be some analysis of who those people are.
Yes.
Let's leave the discussion about an additional
meeting. Can I ring you back?
Thanks, Anne.
Oh, no, I'll speak to you later.
Sorry.
Can you go on mute, please, Anne? Thank you. So can we leave the discussion about having an additional meeting and doing a deep dive, which is Kath Perry's final part to that suggestion? Let's take that once we've had the overall conversation on this, because I think it's a good suggestion. So can we focus in on the concern on speed and leaving people behind, please?
Yes, thank you.
So I guess, sorry, just to clarify, when you say leaving people behind, do you mean in terms of what we're doing digitally, or in terms of what I've said today and kind of keeping up to speed with all the goings on?
I'm thinking of patients actually trying to get in touch with GPs, surgeries, and actually have a conversation with somebody that they, it doesn't, sometimes it's not just one conversation they have to have, it's several. And when you're of an age, a certain age, you can't, you need that face-to-face contact with somebody. And unfortunately, we're losing. I understand where you're coming from. you know, to cut down. But actually, I'm being asked, where have the GPs gone, if I'll be quite honest with you, because nobody can seem to get in touch with a GP in my division at all. So I'm just saying it is as I see it for my residents that I actually look after, for the want of a better word. So that's where I'm coming from. It is an age thing when you talk about digital, because most things are done digitally today, and there are some people that embrace it, and there are some people that don't want to embrace it. So we need to be mindful of those people that don't, and I'm probably thinking of more of a mature age group of people that might not want to, because they might not have the actual, other than a telephone, they've got no other way of getting in contact with anybody. Social media and all that kind of thing is very far away from their plans, is if you know where I'm coming from. So that's my thinking. So, you know, yeah.
Yeah, no, I do, and I suppose I guess picking up on that's probably two parts to that question. One is access to appointments in the first place. The other one is actually the nature of the kind of virtual appointment as well. So I think in terms of access to appointments, it's probably very timely that Paddy's come back on. There's the whole kind of GP access. All practices operate differently in terms of how you go about getting an appointment, and I think actually in terms, if it's around about access to appointments, we probably need to, I don't know if Paddy's got an input into that, or I can take that and talk to Lynn Miller about that in particular. I think when it comes to the actual virtual piece of the appointment, I even though I'm an absolute digital advocate, I totally agree with what you're saying. And this is not about everybody should have a digital appointment. This is around about what is most appropriate for that patient. And if that patient has either got a personal preference that says, actually, I just can't engage with this and I want to go and see a GP, absolutely. Actually, if that patient is got a certain condition, a certain presentation that just doesn't lend itself well to a virtual appointment, they're the ones that we need to get smarter at picking up. So and when I talk about, we've been kind of thrust into this and thrust into 70-80% of virtual consultations, that perhaps isn't the right number going forward. And what we need to do now is achieve, we've been forced into this, we now need to achieve that right balance between who does and doesn't need a virtual consultation, who wants to engage with that and who doesn't. And obviously, you know, you've kind of represented a view there that says certain people don't want that. There are people at the opposite end of that scale that absolutely want to sit in the house and engage. So I totally agree with what you're saying, and that's part of our challenge is achieving that balance going forward.
Thank you. Thank you.
Anything further, Kath?
No, I don't think so, thank you. So long as it's being taken forward so that we do know about it, so we can actually guide patients, for the want of it. That's our role, to help people in our communities to understand the changes that are being made. So, you know, that's where I'm coming from. Thank you.
Thank you, Kath. A really good point. Tina.
Thank you, Chair. I have to absolutely agree with everything that Kath Parry has just said. I have been waiting for urgent surgery since last October. Every single appointment I've had with my consultant has been virtually, and I'm sorry, it doesn't work. The doctor, the consultant can't see what's happening with my body. They can't see the problem I'm having. They can only assume with what diagnosis they've given me. And I am the same as Kath. I'm getting loads of people coming to me saying, can't get hold of a doctor, nobody's answering the phone, I can't access Zoom, I can't access Teams, I don't want to talk to a doctor on the phone, I actually want to see a doctor or a nursing practitioner in my surgery. I've paid my stamp all my life, I should be entitled to see somebody in the medical profession for whatever my issue is. And I'm sorry, Kath is right, people are going to get left behind because people of a certain generation will think, well, there's no point in phoning the doctor because you can't get through. There's no point in phoning them because they haven't got an appointment until a week next year. They don't really value me as a person, and I think that's what we've got to address. Yes, I agree that certain things can be done digitally, but not all things, and I think people are going to get left behind, and unfortunately that is going to be our older generation, the very people that we as a county council and medical professionals should be looking after. I'm sorry, I think we've got this one wrong.
Who wants to pick that up? Paddy.
Yeah, I think there's some truth in what we've heard there around how people access services. I think we're also not potentially being very smart in how we respond to this. We're not done with coronavirus yet, and we won't be done with coronavirus for probably quite a long time. It's going to remain endemic in the community for the foreseeable future. The idea that I'm going to have a waiting room full of people, and the traditional GP waiting room isn't a happy picture because it's people sitting waiting to see their doctor, and that soup of respiratory infection sitting beside people who are perhaps frail and immunosuppressed isn't a happy picture. So we can't do that just yet, and we are going to have to work out systems that that people can navigate with some confidence and know that they are being seen. There's also been a huge hit on the productivity. So, you know, every telephone consultation that I do that I then bring back into surgery is effectively taking me 3 times as long to do than it would have done in the traditional GP surgery. And we haven't really addressed that. So I think it would be premature to think we're going to go straight back to the way things were, because that's going to expose people to risk and the potential for further waves of coronavirus, certainly for the next foreseeable time. But I don't think we've done enough work on exactly how the model should work and be as productive as it needs to be, and then explain it to people and in simple terms, so they aren't saying to us that the GP is shut. We've never been shut. It's just we want you to phone us first, and so we've missed out on some of the comms and messaging, I think, and it's all been a wee bit too complicated. But I don't think we're finished yet, and we do need to sort of do some work on how this is going to look as we restore services and try and get people seen for the conditions they clearly need to be seen for.
Thank you. Tina, did you want to come back on anything that Paddy's said?
No, Chair, just to say that there's a bigger conversation to be had. I think we as a committee need to have that conversation, and we need to engage with Paddy and Stuart at another date, because there's too much information for today for us to take in, let alone Joe Public. We can't be expected to disseminate that much information from today's meeting, and I think we need to come back to it.
I think you make a good point, Tina, in as much as I think this is the starting of a journey. It's a bit like, you know, I guess learning to walk. You wouldn't expect to do that in 2 seconds. We just need to get some base information, which is what we've got today. And I think there's a further discussion to come and to help shape the outcomes. Bernard, can I bring you in?
Thank you, Chair. I agree with colleagues regarding the pace and the conclusions I've come to here is there's a drumbeat message that I hope Dr. Hannigan will take away, and I'm reassured that by his last comments that he has listened to what's been said. And the point I want to make quite clearly is I wouldn't want the organisation to think that there's one fit for all. There certainly isn't, because there's people hanging on the end of this, and I mean, it'd be absolutely rude and ridiculous for me to say that you haven't thought of that. But I think the delivery of this message today hasn't been helpful, and it hasn't been mindful of the patients. It seems to have been a textbook exercise by the CCG and the organisation to get to this point of trying to convince members that this is a way ahead. And I personally can't go with that. And what I'd say to colleagues in the CCG is the delivery of messages, and I've said this before, and I'm still convinced that no one's listening. The PPG have a role to play here. It's all well and good applauding the PPG and tapping people on the shoulder and saying, you're working with the GP practice. Well, I can tell you at the moment in East Staffordshire, we're getting tapped on the back and say, thank you for helping us with the car parking arrangements. Now you go to the other extreme with this conversation. There's some powerful messages here that need to get to patients. What are the patient participation groups for? To try and help with that. So I would ask you to consider again that there may be a role to play, albeit minor, in helping get this message out. Thank you, Chair.
Thank you. We'd like just to pick up some initial thoughts.
I think sorry, I had to drop off the meeting, and I've just picked up those last 2 questions. But I think there's a theme here, and probably if members want to hear or have a further conversation, it's probably with the primary care team. particularly, and the primary care director around the shape of primary care services, particularly because 90% of patients' contacts in the NHS is in primary care, and so how that feels gives a very high level of influence on patients' perceptions of the NHS and services. So I think there is a big piece of work around how that's going to look. The digital piece is only a subset of that, because clearly digital is only part of the wider primary care and the whole sort of general practice workforce model and how things are changing with the advent of PCNs. So there probably is a conversation, a wider conversation to be had there.
Thank you. There's a suggestion on the table, Bernard. Are you happy with that, and that we look to pick that up as a committee in the new term?
Yes, and I really hope I get re-elected to be part of it.
I'll leave that comment on the table if you don't mind. But we welcome your interventions. Paul, can I bring you in, please?
Thank you, Chair. Yeah. Not wishing to minimise the comments my colleagues have already mentioned in terms of digital inclusion, but I think we're slightly missing the mark here in terms of, I think there is something to gain from digital exploration. I think we're doing it as a local authority. I think the fact that we're going to be able to offer patients an opportunity to engage digitally if they want to, and I think that's the message you're trying to put over, really, that it's one of those things that if you elect to take this route, there are benefits, and I think there's good mileage to explore that. And having used that part of the service with my experience, it's worked quite well when it's worked. Obviously, getting to speak to a GP is a difficult one, and I acknowledge my colleagues have put that forward. But what I want to ask is that if we're making that expectation for the public to think that they can interact digitally, is that their expectation that their GP practice will have not opted into this, but have actually been directed as a requirement to give that overall overarching wraparound service that's so vital. To go to your GP, you're expecting a certain standard of care. You expect on your digital officer that's going to be available. So I would like to see that this isn't an opt-in service for GPs to make their mind up whether they want to include it, but more of a direct, this shall be part of your service going forward. And that'll obviously improve the way that patients interact with the NHS on their journey. And I think the advent of an NHS app, that again, if you're capable and that like-minded to get engaged with that side of things, can reach great benefits. We've seen from research from the United States that there's even self-diagnostic apps that can be integrated for certain conditions just based on your mobile phone and being able to take a picture of yourself. So not being able to access that sort of thing will be detrimental and will be a complete shame if we don't embrace that technology. So I'm fully in agreement with this. I think there's lessons to be learned and full steam ahead. Thank you. But obviously bearing in mind the digital inclusion aspect. Thanks.
Probably a couple of things I'd say in response to that. The first is actually a broader thing. There's a revolution going on around us, and best seen in other retail industries. They've completely transformed their relationship with their customers. So if you look at our denuded high streets and the shift to online shopping, I can shop online 24/7, pretty much anything I want, I can get it back. The companies I use harvest my data, represent their services to me, things I never thought I wanted to buy, they point at me. The health service is way behind the rest of the world. If you look at retail, banking, holiday travel. These industries are absolutely transformed their business model, and yet we're still sticking to a very traditional way of doing things in the face of mounting workforce problems and problems with estate and all sorts of other issues. And we our strategy, we are somewhat left behind. If anybody wants an independent view of that, they should have a look at the Public Accounts Committee report from November on digital transformation in the NHS. It's a story of failure in developing and delivering any digital strategy across the NHS. I think the second thing I'd say is just coming back to what you said around needing clarity and standardization of services. There is a level of being able to tailor services to individual needs, and that particularly speaks to areas of deprivation or particular needs. But at the same time, there needs to be some standardization. So as you say, you can access an NHS digital service wherever you're registered with a GP, not at the whim of your GP. So I think sort of our strategy is colossally behind everybody else around us in terms of how we're changing our services. We're way behind how we are leveraging patients' data to improve their individual care in the way that other industries are doing. And we're still not able to do this at a scale and in a uniform way that we can actually then make people understand. So I think the story is not a good one to date on a national level. And as I say, the Public Accounts Committee was pretty damning of our delivery of this over the last 20 years.
Thank you for that, and I wouldn't wish it to totally replace any service of the NHS. I see this as coexisting alongside traditional methods to enhance rather than get in the way of. Thank you very much. Over to you, Jeremy.
I got a feeling he's dropped off, actually. It's frozen on my screen then. So
he has on mine too.
Yeah.
He has on mine. Paul, are you taking the chair while he tries to get back in?
Yeah. Jonathan, you need to ask the Vice Chair to step in.
Please.
Well, Vice Chairman should know to step in.
Yes.
Vice Chairman, over to you.
Thank you very much. I didn't realise Jeremy had dropped off.
Can I just make a point? Sorry about this.
Yes,
Vice Chair. Yes, sorry, Paul. I just want to come in on something that Dr. Hannigan's just said, actually, if you don't mind. No disrespect for what you've just said. I understand where you're coming from when you talk about the high streets. That is a choice, whether you shop in the high street or whether you shop online. There are people that do shop online. I, for one, don't shop online at all for anything, believe it or not, and don't wish to. I like to see what I'm buying before I actually purchase it. Let me put it that way. That's just a personal example. But the NHS has been around for years, and we all pay into the NHS. Where from when you're born, basically, or you start earning money, you pay into the NHS. So I think you've got to bear in mind that it's not a good analogy to use the high street stores in comparison to the NHS. There is a difference there completely. One is to do with health, the other is to do more with social activity, maybe. I don't know. It's just a point I wanted to just put across to you with your, when you mention the high street stores. I'm sitting here thinking, not a really good example to put in its place, if I'll be honest with you. But that's just my personal opinion, Dr. Hannigan. Sorry about that.
I like to be challenging.
Sorry.
Thank you, Kath. Have you got anything to add there, gentlemen?
I'm happy to take the point. I wasn't going to argue the point. I think the previously made point is that one size doesn't fit all, and we need to accommodate a range, but we need to increase our efficiency and our productivity, and we need to make better use of our workforce and our resources, and we're not doing many of those things. And in the middle of it are our traditional routes, which are waiting lists, delay, variability of services and variability of outcomes. all of which translates into people not getting the best care that they could do. And so, yeah, it's complex, but we need to make our system work more effectively, and digital is one part of that.
Yeah,
Okay.
I think I would probably just add to that, and I'm going to repeat the point from earlier, but I would absolutely stress that I am absolutely a digital advocate, but this is about balance. This is about choice, and we're giving another choice, and so I would just kind of stress that, I think.
Thank you, Paul, and thank you very much, Dr. Hannigan, and thank you, Stuart, for that. Thank you.
Okay, thanks. Bernard, I can see your hand is still raised. Are you wishing to come in on this? Bernard, do you want to
I think it's from before, Paul.
No, it's a legacy hand, Chair. Apologies.
Okay. Have we any other questions on this, please? Members?
Jeremy's just letting us know he's lost all internet connection, by the way, for those that are on the call. Thank you.
Okay, thanks. Well, if there's nothing else there from members, that's fine. We're on to the consider that the committee has taken on board the recommendations that you gentlemen have provided. Thank you very much for your comprehensive report. There is a lot in there, I agree, but on the other hand, there are things in there that I think we need to take forward from this committee and revisit with you on the journey that we're going to be expecting to go down the next few years. And obviously taking on board the fact and the lessons that we've learned from COVID and how we've had to manage different scenarios in terms of, as you say, Dr. Hannigan, the sitting patients next to somebody else who's got a respiratory issue isn't ideal. So there are lessons that we are taking on board from this, and I welcome the fact that you are taking these messages further forward and looking to improve the NHS, whether it's overall or whether it's digitally. So thank you very much for your time this morning. And we need to go on to the next item, which I'm going to need a little bit of help there, please. Which item are we on now?
Should I come back in, Paul? Apologies for that. Thank you for standing into the breach.
No problem at all, Jeremy. Happy to hand over.
Technology was beyond me. I do apologise. So next item is item number 7, the care homes for older people. Johnny, are you leading out on this one, please?
Yes, I will. Thank you, Jeremy. First, I want to introduce you to Andrew Jeps and Helen Trousdale, both of whom I hope I see Helen's face, both of whom are very credible, and Andrew's, thank you, both of whom are very credible alternates to Richard Harling, and I'm sure will serve the committee well. We welcome this opportunity. I think it's come at a very apt time. You'll have seen it in the report that prior to COVID, that the quality of our care homes by CQC standards wasn't the best. But it was a significant improvement over the last couple of years. So we were making progress, but it wasn't the best. The second thing you will notice is that people I think have the view that we are a majority player in the care home market, and therefore our influence in the market is greater than it actually is. If you look at the numbers in the paper, although we are a major player, most probably the major player, we're not a majority player. And the numbers highlight that. And other commissioners in the market are the NHS and other local authorities, and a significant proportion of those who self-fund. And I think that's important when one considers this. In view of the cost pressures prior to COVID as well, which were significant, we had a block contract arrangement which appeared to work well. We were doing a joint review with the NHS, the nature of which you can see at the bottom of page 34, but had to be suspended due to the pandemic. And we extended our dynamic purchasing arrangement system, which was also working well. And then came COVID. So COVID hit us at a time that wasn't best for the care home system in Staffordshire. And there aren't really words that describe the difficulties that the care homes have had to go through. It's been terrible, and it's had a huge impact. And they now have, on top of caring for patients, they have significant greater infection control. They've got to manage sporadic outbreaks. They've got ongoing testing. There'll be the issue of revaccination in the future as well. The recruitment and retention of staff was already difficult and may become more so. There's lower bed occupancy. The vacancy rate prior to COVID was 9%, and as you can see in the paper, it's now 22%. And this is largely driven by the self-funding market, and people are voting with their feet. So there's a potential change to the self-funder preference that may be long-lasting and go into the future. We don't yet know. The other thing about this is that the home care market has seen an increase in business. It fell back during the first lockdown, but the 50,000 hours a week were back where they were pre-COVID by June. And we've seen a steady increase in the home care market since, and only in the last month or so have we seen that that level off a little. We have a market review now to look at all this. It's a very dynamic and challenging position, and we don't know quite where we will find ourselves. Thus, we were doing this review, which will present in the late spring, early summer, to see what the appetite for the care home market is in the future, what the care home market might look like. I think if we think in terms of estate, which is a fundamental thing in terms of the care homes, many of these buildings are old, and therefore to be infection secure is considerably harder for them. And yet we don't want infection secure buildings that have no sense of community and people feel isolated within a community. That would be quite wrong. So the challenges in terms of the estate in the future is significant. So it's a very fluid position. The care homes, like all of us, will be living with COVID in the future, and the market review is the first step forward in seeing how we procure and commission the care homes for our residents in the future. Thank you, and I say I welcome this. It's come at exactly the right time. Thank you, Chair.
Thank you, Johnny. That's really helpful just to position this debate. So I've not seen any hands go up just yet, but I do welcome some of the people who haven't yet today had the opportunity to speak if they want to just pose some of those questions. I'm still waiting to see a hand. So let me ask you a question. This is obviously an exploratory starting point to a wider piece of work, Johnny. When is the right time that you will have, sort of more of that work done so that we can actually see some of the outcomes? Because I think you're talking about potentially a fundamental shift in how people take this sort of provision.
Well, that's a possibility. The fact is, we don't know. We don't know whether the appetite for a care home is short-lived, and people will go back to that. We've yet to look at that. And the first iteration of what I think will be a more quite a long-term review of the care home market will be in the late spring, early summer. And I just wonder, Andrew Jeps, if you want to come in there with any more clear thoughts on that.
No, I think you've made the point entirely well. There's a lot of fluidity. We might argue whether there's ever going to be a right time, but we're clearly past a very significant wave of COVID. We are moving into a period where the last line of defence is now available that we can foresee, that's vaccination. So we need to take stock, understand how we can continue to improve the quality of care where people do need it in a care home, and the quality of life that has already been mentioned. And in some cases, if there has been a change in the pattern of demand or expectation, to be able to respond to that. Any of the commissioning decisions we make and any of the decisions that providers make are typically very long term, but we'll try to get them as right as we possibly can. And it's a good time over the summer to take stock, to issue a new market position statement and to set a new route forward, but recognising that we're going to have to adapt to whatever COVID brings over the coming months. And we will, of course, do that.
Thank you, Andrew. Sounds to me like you're suggesting that the committee might benefit from a further discussion in September.
Chair, can you hear me? Because I've lost sound altogether.
I can hear you.
I can't hear you.
Can anyone else hear me or not?
Yes, I can hear you.
Thank you. That's good news.
Yes, I can hear you, and I can hear Johnny.
Johnny, you carry on because we can hear you. But Andrew, can I just ask for clarity? Are you suggesting September is the right time for a further discussion on this?
I think, to be honest, we haven't got an exact date yet because the piece of work we're going to do will be as long as it takes. So it will be at some point late spring, early summer. And of course, we're happy to keep the committee informed of that timeline and for you to ask whatever questions you see fit at the appropriate point.
Thank you. Appreciate that. Charlotte, can I bring you in, please?
Thank you, Chair. Yes, what I wanted to ask about, given the fragility of the care home market, whether the council's block booking system in fact adds to that fragility, because obviously what local authorities do is block book and pay considerably less per placement than self-funders. So it adds into the fact that care homes' financial viability is under great stress at the moment. So I'm wondering what your view is about whether the local authorities, who effectively are subsidised by self-funders, are adding to the problem rather than helping the care market, if we are interested in the private care market, continue in these present challenging times.
I'll ask you to come in a minute, but I have a particular view, Andrew. With the vacancy rate dropping from 9 to 22%, if I was running a care home, I would want the security of knowing that a certain amount of income was to come through the door, no matter how many people were taking up the beds. So I think there's two ways of looking at that. Andrew.
Yes, that's a good point. We don't have any evidence to say that it's causing more fragility in the market. I think that's a good point that you've made there. Different homes, of course, have different business models. Some expect a higher proportion of self-funders. Some expect a higher proportion of business with local authorities. There is a process where homes bid and set the price that they believe is viable for them. And then we select our block purchases on that basis. But we will continue to review all of those techniques by which we get good value for the council funded people that we place and making sure it's sustainable as well. And obviously we have an interest in making sure that care homes can provide good quality care.
Did you want to come back, Charlotte?
Yeah, just to really say that, I mean, obviously the council pays considerably less than self-funders. And I think this is always a bit of a tension because obviously self-funders are effectively subsidising the sort of local government placements. And, you know, given that we are almost in a sort of transition period in terms of, you know, the crisis that has been occurring in the care homes, largely because people were discharged from hospitals until April 17th without being checked for COVID. So needless to say, infections spread within the care homes. But we're almost at a watershed now because obviously we're a sort of a pre and post COVID situation where people's attitude towards care homes will change and whether they want to use care homes. So it just seems to me that this is a time when we as a council have to consider what we are doing. And of course we are having an input into the market by by creating our own care homes, which I very much welcome, because I think we otherwise will be very much at the mercy of the fragility of the private market. So I'm all in favour of us having our own input, but I do think that while we're in this transition stage, that we do really have to consider what impact we have. And I appreciate Johnny's point about having a safe supply of placements, which is better than having a vacancy. But I just think it's something we have to look at in terms of the future market, because we're going to have an increasingly older population, and also we're going to have increased fragility at the point at which they go into care homes. And also the other issue is the ability of care homes to cope with dementia. Now, clearly, some care homes do deal with dementia, but others don't. And I think the demands on those are going to be greater.
Helen, I noticed you've indicated. Do you want to come in just to pick up some of Charlotte's points?
Yes, thank you. Thank you for your question, Charlotte. What I would say is the way that Staffordshire has approached block book beds has probably been different to other local authorities' approach. So we have undertaken the sourcing of block book beds through an open process with the care homes, and we don't set a rate. So I think the advantages we've got is the care homes that have responded to us, and this is probably why it's been so popular, have been able to set a price that they believe is sustainable. I think the added complexity that we have now is obviously they'd set that price at a point when they had 9% vacancies, and they now have more vacancies. But one of the things that we did do as part of the COVID support to care homes that Cabinet agreed in the summer, if members will recollect, is we offered something called a block book bed retainer, and we extended that to include not just nursing homes, and certainly it does include dementia nursing beds, Charlotte, also for residential care. And we've also included residential care for dementia beds in that process as well. Overall, the feedback we're getting from our care home providers is they very much welcome our approach to block book beds. As Councillor Maman was saying, that does give them some surety and some assurance in terms of the capacity. Also, from the point of view of the fees that they charge to private customers and for spot purchasing for as and when it happens, obviously with the block bud, they're guaranteed 52 weeks a year income, and they don't have to factor in any weeks when the properties are vacant. And that also gives us a little bit of a better price advantage. But as I said, the prices are set by the care homes who respond through our DPS system. We are about to go out again to secure some more beds, particularly for dementia, because I absolutely agree with you, Councillor Atkins. The need for dementia is increasing, and I think we'll also find that as more people are being supported at home, the likelihood is they'll be supported for a much longer period of time at home, both through health and social care services, as their dementia progresses, for these obvious reasons that people don't necessarily want their family members to move into care homes at the present time. So we'll find that as people come to us, they'll come to us more at the point where people's needs, perhaps for dementia, are more acute, which means that a specialist dementia home is more likely to be needed at that time.
Thank
you for that. That's lovely. Thank you.
Great. Thank you for those questions. Whilst I'll just invite anyone else to ask anything from this report, understanding it's indicative and a starting point. I do have one question which relates to page 32. I accept in terms of the progress on the number of inadequate care homes in Staffordshire has been good. It's reduced from 44% of care homes to 35%. That's still 50% more than the national average. So is that a concern for you? And what could we be productively doing about that?
I think that the first thing to say is it will certainly factor into the review, because the quality of care and the quality of the provision is what we're about. But the second thing is that I think that COVID will result in a paradigm shift in the care home market, such that all bets are off, I expect. I particularly think that's the case for many care homes, certainly not all, but for many of the small care homes in terms of the estate provision. So I think this is a window of opportunity for us, therefore, to increase the quality of care markedly. I don't want to set hares running, and I don't want to preempt the report, but I think this is an opportunity to change the landscape. Andrew.
Yes, those care homes which are labelled as requires improvement, well, that is what it says on the tin. They need to have an action plan that will get them to a good, or indeed an outstanding rating by CQC. There is a timeline for doing that, because to make that change they need to have been re-inspected, and that doesn't happen immediately. The gap between each inspection can be quite considerable. We've done a number of things to try to support care homes to become as good as they possibly can. That includes, well before COVID, establishing a provider improvement response team, so with nurses seconded from the CCG to provide not just that response to quality concerns, but that proactive support to care homes to really improve their quality, particularly in nursing care. And you can see from the graph that we are seeing some progress from doing that. The other thing we can look at is the breakdown of categories that CQC put out that show us where we have the biggest challenges. And the greatest category is really around the leadership within the home. If you think about the pressure and the responsibility that lies with a manager, or in the case of a nursing home, a nurse who has a shift leadership responsibility, that's pretty significant. So a lot of our training has been targeted at those particular roles to try to improve the quality and improve the support. And indeed, during COVID, one of the things we've done as well as we possibly can is to provide the best support that we can to the people who are running care homes and who are trying to do the right thing. It is a challenging and lonely time sometimes if you're in a small provider with that responsibility. So yes, we do have all the things you expect, the relationships with CQC where care homes fall down on the quality that we expect, but we also want to provide a supportive environment for those leaders and managers who are trying to do the right thing. And we think that with the joint working with the NHS will help push quality in the right direction.
Thank you, Andrew. I think that last point in terms of working with the NHS, I think it's been demonstrated certainly through the COVID response. That's been fundamental. So that partnership working, I think, is to be welcomed. Charlotte, you're the only one indicating. Is that a legacy hand?
Sorry, yes, it is.
Thank you. Andrew, Johnny and Helen, thank you for sharing with us the sort of a starting point to the journey. I think the last two items on this agenda have really been sort of taking the committee with us in terms of exploring what the council's thinking and partners' thinking is on this. So thank you, all three of you, for that. And in which case, if there are no more hands, I will move on to item number 8, which is district and borough scrutiny activity. Jonathan, is this one for you?
It's really one for any member that wants to add anything that's not included in the report, Chairman.
So thank you for that. So I should just mention 3 things in terms of Chairman's activity whilst members are just considering their actually that's the next item. Let's keep on item 8. So is there any updates for any of the districts, please?
None from Staffordshire.
Thank you, Anne.
Lichfield, Chairman, I believe you're expecting a verbal.
You're expecting me to give a verbal or the other way around?
No, the other way around, I think.
Okay.
It's very brief. Our Community Health and Housing Committee sat on the 10th of March. You'll notice that community and housing are also on it. Health actually plays a very small part of this committee's work. But as usual, we had issues over the future of the George Bryan Centre. I see that that's in our work programme for next year, but it's not dated, but it's there, thank goodness. The future of community hospitals, you've also put into the work programme, although it is part of the STP consultation process. And what else was it? Oh yes, the CCG, Marcus Warnes, I believe, has been in touch with you rather than us over the issues of concern that some of our councillors have. And finally, we're left with the Burntwood health situation, where there is pressure to provide a new health centre in Burntwood. Of all of these issues, you left quite rightly the Burntwood issue to Lichfield District Council. You left the Marcus Warnes to Marcus, and the other two issues, because they're county-wide, you've placed onto the Health Select Committee agenda. So thank you.
Thank you for that summary. So absolutely right. We'll circulate the response from Marcus Warnes on Seaston and Peninsula. We'll circulate the response from the system on George Bryant. And I think the STP consultation will end up as an ICS consultation, but in broad terms, they mean the same things, but that'll be something for the summer work programme. But appreciate the update. Do other members have any other updates? Okay, I would just ask those specific representatives from district and boroughs just to bear in mind as the County Council moves into its next session next year that we should probably be looking to follow the lead of the ICS in looking at some of those preventative and impacts that we could be working on. And I think if we're going to deliver anything, that we probably need to take the lead from the Health and Wellbeing Board. And I would encourage members from districts and boroughs just to have a look at the latest strategy work that the Health and Wellbeing Board is doing. Last week's session on obesity, I think probably gives an indication as to where other members within the system have got their minds and would like to try and focus. So I can only encourage members to pick up those packs and look at how that might reflect. Okay, item number 9 is just the future work programme. This is where I just need to update you in terms of a few things that have gone on in the last, since we met last. First of all, we continue to work on a set of health dashboards. I would suggest that in the absence of seeing a first draft, that we put this on the work programme for a meeting in July, so that the health system can come and talk to us about what their proposals are for those health dashboards. That might encourage them to bring forward a health dashboard so that we have something whereby we can temperature dip and have a view as to how the system is performing as a committee. Second of all, I met recently, yesterday it was, with the new chief executive of Health Watch Staffordshire. Simi Akhtar has moved on, and Simon, I want to say Fuller, have I got it right?
It's Fogel, Chairman.
Fogel, thank you. Thank you. That was my pop knowledge coming out, wasn't it? Simon Fogel is taking over as the chief in relation to Staffordshire and Stoke-on-Trent. They are likely to come with an annual report or build an annual report. We didn't see them last year, so I would suggest that we added them to the work programme for August or September, depending on when that annual report is due, because then we can ensure our work programmes are aligned. And I think today we've discussed two other elements, which is an ongoing discussion on digital and also an ongoing discussion on care homes. Members, sorry, Jonathan.
Yeah, there's also, Chairman, the annual vaccination programme that you mentioned you might want to look at later in the year.
You make a good point. Thank you. Do members have anything else that they want to quiz, question, challenge? Bernard.
Thank you, Chair. There's something around the digital world that's making me think that it's moving at a pace. And I think we ought not to lose sight of what's happening in the NHS on the digital front, because it touches every patient at some time in their life. And as has been said by colleagues today, we're asked questions and we're asked to help them in some detail, and I want to be sure that I'm keeping up with what's going on.
I think the strength of feeling was shared not only by yourself but also other colleagues. I thought Paul Northcott's, before I got cut off, his contribution was useful just to balance that debate. I'm going to suggest that for future meetings, we've got a meeting in June which will be principally training of the new committee, a meeting scheduled for July where I think the ICS will want to bring forward some more conversation on that, maybe linking to the STP consultation, and I guess we'd want an update on COVID, but given what Bernard's just suggested, do we want to bring forward digital in August alongside Healthwatch?
Yes, please.
If no one's dissenting, we will go with that. Okay, does anyone else have any further comments on the future work programme?
All I would say, Chairman, that's obviously at the discretion of the committee after the annual meeting in May and obviously the elections. So
I'm sure some of us didn't need to be reminded of that, but thank you, Jonathan, for that clarity and confirmation. And obviously we can't bind the hands of the future, but maybe we can leave a trail of breadcrumbs that people might want to follow. Does anyone else want to add anything to the future work programme? So on that basis, just before we close, I did want just to say, given it's our last scheduled meeting of the 4-year electoral cycle, I just wanted to say 3 thank yous. First of all, thank you to all of our guests over the years who have attended and provided clear and precise reasoning for their decision making, even if we weren't always completely in full agreement. Second of all, thank you to every member of this committee, past and present, for their diligence in reading the papers, focusing on the health issues and the outcomes for our residents in Staffordshire. And finally, thank you to the officers over the last 4 years who've been involved, Jonathan, Mandy Patterson and the ever-present Nick, for their guidance and tolerance. And otherwise, I think it just leaves me to thank everyone and to wish you well going forwards. And I'm sure our paths will cross again going forwards. Thank you for this morning's input.
Thank you, Chairman. Thank you.
Goodbye. Thank you. Thank you.
Take care.
Bye, everybody.
Bye-bye.
Thank you. Thank you, Chair. Thank you. Bye.